sehr gerne. Ganz tolle, bunte Bilder.
Hallo, ich bin Henriette. Ich bin mehr als mein Herzfehler und ich freue mich gerne.
Ich bin Nuri und ich bin mehr als mein Herzfehler. Ich tanze für mein Leben gern.
Welcome in this wonderful church. I think that the topic of ours is very well suited to this location and vice versa. I would now like to give the floor to our host of this morning. Dear participants, dear patients, dear colleagues, I'm very happy that after a certain time we are meeting again here in Magdeburg, and we have a very busy program indeed, a very complete program, and I would like to ask Mr. Wolfgang Bett. He's the State Secretary for the Ministry here in Magdeburg, and he's going to inaugurate this conference. Channel number 1 is German and 2 is English, for those who need translations. Mr. Back, thank you very much for being here. Dear Mr. Grabitz, dear Ms. Sänger, dear participants, I'm very happy to greet you in my capacity as the State Secretary of the Ministry of Health here to the Symposium of Fontan-Hearts. And this location is very special. It's the old civil church which in 1524 hosted Martin Luther. And he talked about justice and injustice. And legend has it that the church was so full that people climbed on the trees outside in order to be able to look inside the church's windows to see what was going on. And after this after this event, Magdeburg was one of the first cities in Europe that was pioneering the Protestant movement. And 350 years ago, Otto von Guericke was buried here. He was a universal genius. He was a politician. And after the complete destruction of Magdeburg, after the 30 Years' War, he helped reconstructing it, but he was also a scientist. He was an experimental physicist, and he researched the air, and he experimented in very extensive ways about this. His grave is here in this church somewhere. We don't know exactly where, but there is a memorial in the basement of this church. And I think you picked the right location for your topic, because your topic is very scientific and needs science, needs research. And research and science means exchanging experience and information. And I wish you all a wonderful day, a very fruitful day, and I hope that you will have some progress, that you will make some progress in your topic, and that you can actually achieve something for your children, for your patients. So I've looked at your agenda, and really it is very, very busy, so I don't want to steal time away from you, and and this is why I would like to close now. You, and especially Ms. Sänger, are very close to my heart. I've known Ms. Sänger now for some years, and I cannot say how much I admire her in her work. She is affected herself by this topic, and we are here because of her. We have an international conference here now because of her, and it's not a topic that is something that people talk about on a daily basis. And this is exactly why it is so important, and we do value this. Thank you very much for your efforts, and thank you very much for your attention. I wish you a wonderful day here in Magdeburg. and that you may take away a lot from this wonderful city. Thank you very much. Thank you very much, Mr. Beck. I'm very happy that you came. Now I would like to give the floor to Ms. Sänger so that she can say a few words and then also present the team. I'm not going to speak a lot. I'm very happy that I will have my team around me here on the stage, and I hope that this inauguration ceremony will be worthwhile. So in 2012, I founded Fontan-Herzen EV in order to have science for our children, because it is vital. My daughter was born with a Fontan heart, and when she was born, she didn't have a chance, really, a very slight chance. She suffered 8 heart surgeries and 1 stroke, with all that this entailed. So I know what all this means, and I also mean how tired we are sometimes as parents, as well as the tears for all those who didn't make it. I'm wearing black because our association is in mourning, and this is why we've been fighting for more information for many years, more information for everyone, and we need a better interdisciplinary work. And I'm the chair of the association, so in this role, I do so many things. I do the networking, I go on conferences, I make sure that we have enough funding via donations and subsidies. We also have a hotline, a telephone line. We organize this conference, and we support research, and it is very difficult. It is a lot of work. I'm very happy that we have more and more support, and I'm very happy that I have my strong team behind me. As parents, we accompany our children every day with all the challenges, because their journey is very challenging, and we're always present with in all the interventions and all the doctor's visits. No doctor can be there with their patients everywhere all the time. But I wish we had more physicians as you, who take us seriously and who, with us, work towards our common goal. I thank you for your commitment, and now I'm going to give the floor to our 3rd chair. Our 2nd chair is not able to come. She has the flu. Good morning. Yes, Steffi just said that we will use this symposium this year also to show you the faces behind the work. So Steffi Sänger and everybody else, and we try to distribute the work more evenly. So I am the mother of Anna. She's also here on stage, and she's going to say something too. And she was born with the left heart syndrome. So she's well, and she's doing fine, but still, as parents, we are always concerned, and we take this concern everywhere. And I have understood that especially other parents help me and support me. And they are the ones who understand me most and best. And this is why I am a voluntary working for this association, but because only the heart families know exactly what it means when the child during the night suddenly stands before me, says, "Mama, my leg hurts. Mama, my head hurts," and you awake and you're lying there and you don't know whether the night will be calm or not. And we support each other in this struggle. And yes. Because there are the days where my heart child is not very strong, where she's bloated in the mornings, and where she is also afraid of the future. And this is how we parents can support each other. We know that every progress, every story is different, and the syndrome doesn't mean necessarily the same for everyone. But we are united in our fear to overlook something. And now, especially that someday we might not be there on time and miss a clue. And we want you to create a network. We want you to give us your knowledge so that we won't come late again. Thank you. Now, I'm going to give the floor to Fami Paul. We are Stephanie and Edgar Paul from North Rhine-Westphalia. For the last, we've been members of the Fontan-Hearts-App Association for 11 years now. Our son Julius, half a year after his Fontan surgery, developed a bronchitis. He is standing here, by the way. So we needed help and information, and we hope to have an exchange with other affected people. And indeed, in this community that we have here in these associations, we felt understood, and now we can make others participants in the information that we have. For example, the fact that how important it is for Julius and us in 2015 meet Dr. Dori in Philadelphia. There, he was the first patient from Germany to be treated there, and knock on wood, he is cath-free. So we are committed with the work of this association because we are convinced that the networking and the cooperation of specialists from different fields of expertise help everyone, help our children, our teenagers, and also the adults and the parents. So I wish you a successful day. My name is Thomas Sänger. I'm Steffi's husband, and I'm also actively engaged in the work of this association. And I'm convinced it is very important to bundle knowledge and to find the proper medications. So we traveled to Dr. Oetkens in the US, where our daughter Lara had a minimal invasion, and this saved her from acute risk of her life, and we could also gain a valuable time. What else do? I accompany Steffi to everything that is important, conferences, meetings, everywhere in Germany. And I also shoulder the hard work, the dragging along of our books, and I help her to set up the stands and many other things. So what is my wish? I wish that the physicists and doctors in Germany work together more intensively, like they do in the US. I don't understand. In Germany, we have a fairly small group of patients, and there's no registry and no register. Basically, usually we have a register in the hospitals, and then the hospitals can only use this pool of patients. And I'm very happy that there are so many different doctors here now who can take the opportunity to network. Hello, I'm Susanne Vogt, and I'm Ben und Nuri Vogt's mother to 9-year-olds. Yuri had many complications, and he is listed for a new heart. I have been a member of this association for 6 years. For me, it is community, it's strength, it's networking, it's exchange, and it's also progress and knowledge. So as parents, we are connected and we exchange information. Most of us are not medical experts, unfortunately, but we see our children every day. A few months ago, a doctor said to me, "Ms. Vogt, bitte don't apologize when you have questions. It is the most normal thing for you to ask me anything that you want to know. This is about your child, and whatever you have to ask is very important for us." Sometimes we ask too many questions, and I think that must be very stressful in your stressful day. But please use our knowledge and talk to us as parents. We all do this for our children and for our children's future, because our children are so much more than just a failed heart. So we have prepared a little video for you. Could we please see the video now, please? I'm so much more than just my failed heart.
Hallo, ich bin Tore. Ich bin 9 Jahre alt.
I'm 9 years old.
So viel mehr als mein Herzfehler.
And I'm so much more than my heart.
bin Luis, ich bin
And this is what I like to do.
Und ich bin mehr als mein Herzfehler. Und ich male gern. Ich bin Maxim und ich bin so viel mehr als mein Herzfehler. Ich liebe es, Lego zu bauen und zu spielen. Ich bin Charlotte, ich bin 9 Jahre alt. Ich bin mehr als mein Herzfehler und ich baue gerne Lego.
Unfortunately, we can only hear it via the main room. But these children, they all say, "I'm so much more than my heart fault, my heart defect," and they all present the things that they do.
Hallo, ich bin Henrik. Ich bin mehr als mein Herzfehler und ich komme gerne.
Ich bin Nuri und ich bin mehr als mein Herzfehler. Ich tanze für mein Leben gern.
This little girl is dancing. Our thanks go to all doctors, researchers, scientists, and medical professionals, and everyone who is supporting us. I'm Anna. In 2011, I was born with half a heart. So in comparison to many others, I'm very well. I feel very well. But my future is uncertain. And when I ask my mom whether my heart circulation is going to fail as it fails in other people. I see in her eyes that she doesn't have an answer to that. So what we wish for is a fearless life. So please interchange your information and a network so that we can have a lighter life. So thank you very much to Steffi Sänger for organizing this event. Thank you very much. That was really very moving. We also have our Superman here because he came here with Jenny, his mother, and his brother, and they they participated in the get-together last night. So I think this has moved our hearts. So thank you very much to everyone here in this room that you are here, because with your participation, with coming here, you show that you really are committed to our children, helping them, and that you accompany us in this journey. So one more thing, we have Nena here. Years ago, she started with a documentation, which is going to be very interesting once it is finished. So children were accompanied over many years, and there's also some footage with Professor Fontan, and I think that only is very interesting. I remember we met him in Bordeaux. Many people told me I would have loved to accompany you to see him. Now, unfortunately, this is not an option anymore. But I think this documentary is going to be very important. So I would love for you to have some time, spare some time to talk with her. So now the floor to Mr. Grabitz, Professor Grabitz. I'm not sure about the time. We said a quarter of an hour. We're already over time. Yes. 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 Well, the children. We let the children talk, and it was the inauguration ceremony. So I think this is very important. This was very close to our hearts. So I would like to ask your forgiveness. Last year, we overran for 2 hours. So really, we are very, very strict this time. So we will switch off the microphone after the allotted time, and then you will have the hand microphone to finish your last sentences. I apologize beforehand, but this is thinking of everyone and trying to conclude this event on time. Thank you very much. Now let's breathe, because these stories that we've heard from the point of view of a physician is very special, because it takes us back into the situations. Now, I would like to ask Professor Wiebke Jortal, and she's going to talk about the experience in the treatment of PLE and plastic bronchitis. She's come from Denmark, from Copenhagen in Denmark. Thank you.
Well, thanks for the introduction.
Of the patients with a half heart. It means a tremendous amount of motivation for us to hear these stories and to see your engagement in the in our work to help your children. So thank you very much for the very touching testimonies you gave today. What I'm going to talk about today is one of the many challenges that our Fontan patients are experiencing, and that is some of the challenges that relate to the lymphatic system. We have in Copenhagen started a unit where we treat some of the diseases related to the lymphatic system, and especially the two that I'm going to talk about today, the plastic bronchitis and the protein-losing enteropathy. What we have done is in close collaboration with the group in Philadelphia at Children's Hospital of Philadelphia. And I think when you look at the program today, you would see that a lot of us are very inspired and are learning from this group in Philadelphia, where they have made a tremendous effort and are doing major frontier works in this area. You all know the patients with the Fontan, and some of you may also know the problems related to the lymphatic system. This is a young man. I did the operation for his hypoplastic left heart syndrome 14 years ago. And some years after he had the Fontan completion, he started to develop problems related to his lymphatic system. He had failure to thrive, he had growth retardation, he had diarrhea, he became very fatigued, he was not able to attend school any longer, he could not play with his peers and participate in normal daily activities. The other group of patients I would like to talk about are those who have plastic bronchitis. The plastic bronchitis is a disease where patients suffer from serious coughing episodes, thought to be either pneumonia or allergy or asthma very often, but turn out to be related to the lymphatic system. They will cough for hours and then cough up material like this, which is coagulated or stiffened lymphatic fluid that almost behaves like rubber. Before I tell you how we now treat these patients in our lymphatic unit, I would like to talk a little bit more about the basic knowledge we have of the lymphatic system. I know that for some of you this will be very basic knowledge, but I also know that there's some of you who may not have heard about how the lymphatic system is working. If you look here at the left side of the slide, you would see the blood vessels, the arteries and the veins connected with capillaries. And here is the exchange of nutrients and waste products in our tissues. So the blood is running here out into the capillaries. Then fluid is filtered out to all our cells and tissues. And in that fluid, there will be nutrients like amino acids, small proteins, lipids, oxygen, whatever our cells need for functioning. The fluid that ends out here among the capillaries needs to go back into the blood circulation. Previously, we thought that this fluid would enter into the venous system and then be carried back. Now we know that about 8 liters per day is not transported back in the veins, but is transported back in the lymphatic system. So every day 8 liters are filtered out and runs back into the lymphatic system and is transported all the way back into our blood circulation. The majority will enter the blood circulation close to the heart. The lymphatic system does not have a heart to pump the lymph around like our blood system. The lymphatic system has a motor that's sitting in the small lymphatic vessels. Here you can see a human lymphatic vessel that we have taken out of the abdomen of an adult who had surgery for adipositas. So we could take this vessel out and look at how this vessel is working. And as you can see, it is contracting very forcefully. This contraction and the placement of small valves in the lymphatic vessels is what drives the fluid back to the blood circulation. So with this system, fluid will be pumped back into the blood circulation. And these small vessels here are very powerful, as you can see. In the normal situation, for those of us who have a full heart, the pressure where the lymph is entering is about 4 to 5, what we call millimeters of mercury. And here you can see an illustration made by Dr. Dori from Philadelphia, where you see a lot of lymph coming from the liver, running into this main thoracic duct and entering into our blood circulation. When we deal with patients with a half heart, we as surgeons has changed the blood circulation through 2 or 3 or more operations. The operations are good for the patients. The Fontan operation is good for the patient, but it does have some backsides, some things that are not good for the lymphatic system. Because now the pressure where the lymph is entering is no longer low. It is increased compared to what it should have been. So instead of being 4 or 5 millimeters of mercury, it's now maybe 12, 14, 16 milliliters of mercury. It may sound as if it's a small increase in the pressure, but it does have an impact on the on the lymphatic system when it's going on for years. So on the illustration, the video, you can see here that now the lymph has problems getting into this higher pressurized venous system. And the other thing is that when the pressure here is increased, the pressure in this system is increased, more fluid will be filtered out in the capillaries, and more fluid has to go back here. So there are 2 different challenges. More fluid is produced, and it's more difficult for the fluid to get away. And that was what I thought could be compared to a highway, where you allow more cars to get into the highway, and at the same time, you remove some of the exits, so you make it more difficult to get away from the highway. So that is what the lymphatic system is experiencing. It is challenged by being congested. When the lymphatic system is exposed to this challenge for many years, it will start to develop new exit roads. It will try to find ways to get away from this congested system. And this is what you see here, that the lymph that should go this way and up here starts to make ways into the gastrointestinal tract, because there is a very low pressure in our gastrointestinal tract. So instead of running here, the lymph will penetrate out into our gut and get lost in the intestinal tract. On the right side, you can see the inside of the intestine in a patient who has protein-losing enteropathy. And here you can see the lymph that is entering into the lumen via these new exit roads from the lymphatic system. Here we have placed dye in the lymphatic fluid, so we can easily see how the lymph is lost to the intestinal tract. When we are treating these patients, we are looking at the patient from a very broad perspective. So in Denmark, we use the algorithm that has been developed by the people in Philadelphia and has been published by Christoph Bauer, who is here. I can't see him right now, but he's here and is going to talk later today. This algorithm, I don't expect you to see all the details from your end. It's just to tell you that there is an algorithm that will guide us with what we are doing and in what to do first and what to do second. The top part of this is what we're doing first is to try to optimize the Fontan circulation if needed. If there are stenosis, collaterals we need to take care of, we'll do that. Then we will put the patient on diet and we will try medical treatment. If the patient is doing fine on diet and medical treatment, then we will leave it with that. If they're not doing well, they continue to have problems, then we will start to look for the lymphatic problems and see if we can treat them. The last part here is a major undertaking, and it's not without its own risk. So it's something we will only do if the patient cannot be treated with medicine and diet. When we start the lymphatic workup to see if we can do something about the lymphatic system, we start with a non-contrast MR scan that will show us what the lymphatic system looks like in our patients. Based on these images, we will be able to see if there are fluid, if the thoracic duct looks abnormal, if there are lymphatic vessels in areas where they normally are not present, and that will guide us to go on with further investigation. Next step is to do an invasive procedure where we inject contrast into the lymphatic system at different areas to find out where are the leaks, where are these exit roads from the lymphatic system. So we start in the cath lab. It's usually a day-long procedure where we start with using ultrasound and X-ray in order to find the lymphatic vessels to put contrast in. So here you can see an injection in the liver, and in these X-ray images here, you can see this is part of the leg, so we can see the inguinal where we inject here. We inject in the inguinal node. Here we inject in the liver. And with this technique, we can visualize where the lymphatic vessels are, and then we know where to inject the contrast when we then move the patient to the MR scanner. In Philadelphia, they have a hybrid suite where they have the X-ray right next to the MR scanner. That is the optimal setup. In Copenhagen, we have to take the patient 20 meters down the alley to get them to the MR scanner. So we move the patient to the MR scanner, and then we can inject contrast in the needles that we have previously placed in the right locations. So here you can see some contrast videos where you see the contrast coming in here from the inguinal nodes. running up towards the abdomen here and up here to the thoracic duct and entering into the venous system. And here you can already see that part of the intestinal tract gets some of the contrast, which is wrong. It's not supposed to go there. So already with this injection, we know that there is a direct connection from the lymphatic system to the intestinal tract. On the right side, you see what we find when we inject contrast into the liver. And here we can see that part of the duodenum is filled up with contrast. Lymph with contrast is running directly from the lymphatic system into the gastrointestinal tract. With this knowledge, we now know where the lymphatic vessels are that we are going to occlude back in the cath lab. So we transport the patient back to the cath lab, and then in the cath lab, we will glue the lymphatic vessels that are anomalous. So we have the needle here, we have the glue here. This is a gastroscope that we have inside of the gastrointestinal tract in order to see that we place the glue the right place. When we've done this procedure, we take the patient to the intensive care and to the ward when they can tolerate that. We wait 3 to 5 days, and then we do a second procedure if we need to make sure that the pressure in the venous system is decreased. In the beginning, we did this second procedure as a surgical procedure. Now we do it as a percutaneous procedure. The idea in this procedure is to make the lymphatic fluid entering into the venous system and then have the venous system entering into a part of the heart where we have a lower pressure than we have if it enters into the venous system. So when we do it now percutaneously, we have a CT 3D reconstruction of the heart that we're going to work on so that we can see where to place the stent from the vein here to the, in this case, the left atrium. So we base the procedure on the 3D CT scan. Then we have the patient in the cath lab and have catheters different places in order to place a balloon here and then a stent here that will connect this place where the lymph runs into the vein with a low pressure area in the heart. Doing this procedure, we are now able to help the majority of the patients who suffer from these problems. And I do say help, I do not say cure, because we cannot cure the patients completely. We can make them a lot better. We cannot make them completely healthy with this procedure. And I think that's very important for you to know that this is palliation, making their life much better for the patients, but they're not being cured. The other thing is that we can see that these patients, this young man who was the first one we did, is growing. He gained 10 kilos of weight in the first year. He is now attending school again. He's playing with his friends. He has less diarrhea. But now, almost 3 years since his procedure, he's starting to leak a bit again. So we know that our procedures will make our patients good for some time. We don't know for how long. We do expect that some of them will come again with the same problem or new problems related to the lymphatic system. The other type of patients we're treating now is the patients with the plastic bronchitis. Some of you have seen those casts that they cough up. Some of you may not have seen it. Here are 3 examples of casts coughed up by patients with plastic bronchitis. It's a risk that patients who have these problems may choke on it. They definitely have serious problems with the breathing when they have these casts. This is an illustration. This is
Are there questions? Brief questions? No? So then we will leave all the questions for the Q&A afterwards. And now I would like to ask David Renaud. He's going to talk about the metabolism in Fontan. So he is going to make an argument for the ketosis. Was mache ich, um hier die Folien zu wechseln? Okay. Vielen Dank. Also ich werde mich kurz fassen. Es geht um den Stoffwechsel im Fontan-Kreislauf und ich mache ein starkes Argument für die therapeutische Ketose. Das ist eigentlich der wichtigste Satz meines Vortrages. Die Mitochondrien sind ja ein wichtiger Teil des Herzmuskels. Und so sehen wir das Herz normalerweise als eine Doppelpumpe, an die zwei Kreisläufe angeschlossen sind. Mit Fontan haben wir zwei Kreisläufe mit einer Pumpe. Und deswegen ist auch die Herzleistung eben begrenzt. Und die wichtigste Frage ist, ob es hier bei dem Stoffwechsel um das verlorene Kind der Forschung geht. Also bedeutet das, dass
Werner Forssmann invented in 1929 cardiac catheterism. In 1937, Hans Krebs discovered the Krebs cycle, and 2 years after was the first article to consider the chemical nature of heart failure. And slowly, metabolism is definitely a topic that is coming back in cardiology. It is already present in clinical guidelines in adult cardiology with the SGLT2 inhibitors. It is also in research, and this is where we found that SGLT2 inhibitors are related to ketosis. And it works also in the case of the Fontan circulation in small cohorts. So the way of working of SGLT2 inhibitors is to create a mild ketosis by inhibiting the reuptake of the glucose in the kidneys. So, yeah. So let's dive to the power plant. The mitochondria is generally called the powerhouse. As we speak in the heart about the pumps, so I changed to power plant. So there are 3 important steps to produce biochemical energy and to convert it into a mechanical movement in the heart. The first step is the substrate utilization. This is basically the Krebs cycle. How to convert fatty acid, glucose, proteins into energy. Then the second step is the oxidative phosphorylation. So this is the electron transport chain. And especially in the heart, because at the end of the ETC, we have production of ATP, so the molecule of energy. And this molecule of energy needs still to be transferred to make a move. And this is the role of the creatine kinase shuttle. So today we will focus on the substrate utilization, so Krebs cycle. So what to know about how the heart is working from a metabolic perspective? So the heart is an omnivore. It's able to pump on different substrates like fatty acid, glucose, lactate, ketones, branched chain amino acid. 90% of the ATP produced, so the energy molecule produced in the cardiomyocyte, is used for the contraction relaxation. And a small fact that I point now and to remember in 2 minutes is that relaxation needs more energy than contraction. Substrate consumption in the heart is changing in the life. In the fetal life, the heart is pumping mostly on glucose and lactate because the fetal life was once called the Everest in utero, and this relates to the fact that this is a hypoxic field. There are some questions when the shift to fatty acid is starting. Originally, it was thought to be at birth. It is thought now to be a bit earlier. Substrate consumption is also changing with heart failure. Normally, a healthy heart is pumping on fatty acid mostly, with a bit of the rest. But in the case of heart failure, the heart starts to pump using glucose metabolism. It was thought that it comes, that it's a symptom of trying to regenerate the heart. We know now that it's not the case. It's pathophysiological. So, but which heart failure? Because every cardiologist knows that we have different types of heart failure. We have the reduced ejection fraction, so the systolic dysfunction, the preserved ejection fraction, diastolic dysfunction, right ventricular heart failure, so like we see in the pulmonary arterial hypertension, and the Fontan failure. And inside Fontan failure, there were a paper in 2016 published by Book et al. Trying to segment the type of failure. So type 1 systolic failure, type 2 diastolic failure, type 3 normal pressure failure, so situation like FALT, like liver disease, and the type 4 is the altered lymphatic failure. So here the question, as I was mentioning 2 minutes ago, the relaxation is taking more energy than the contraction. So this is what we will consider, because a lot of Fontan patients are concerned by diastolic dysfunction. It's not the easiest to measure, but it is something that is quite prevalent. And what I wanted to show here is that the hypertrophy of the heart in the case of diastolic dysfunction, in the case of, with pressure overload, there is definitely proof of changes of the metabolism toward glucose metabolism. So, in general, what can do ketones in heart failure? Quite a lot we see from literature. Improving the cardiac energetics, improving the endothelial function, reducing the oxidative stress, acting on the acetylation and deacetylation of histones, improving mitochondrial function, reducing inflammation, cardiac remodeling, improving blood pressure, body weight, and blood glucose and lipid profile. And 1.5 years ago, we published an article on the rationale of ketones for Fontan circulation, and there is several elements of the Fontan pathophysiology that might answer to ketone metabolism. We have studies on animal in cardiology with improvements in the cardiac function and in the cardiac remodeling, but most important, we have studies on humans already. We have studies using exogenous ketones. We have studies also on the side of intensive care with severe heart failure and using exogenous ketones. We have also the first small cohorts in the Fontan circulation using SGLT2 inhibitors. So mostly 2 articles. There is also one center that is starting a clinical trial next year. But what about the right ventricle? Small point on this is that right ventricle and left ventricle does not have the same transcriptional pathways. And we saw it in studies with pulmonary arterial hypertension. There are compensatory ketosis that we see in the left ventricle that we don't see in the right heart failure. But the therapeutic stimulation of ketolysis is improving the right ventricle function and suppress the inflammation. And Aarhus did a small study on exogenous ketones in pulmonary arterial hypertension, seeing an improvement of cardiac output and reducing of pulmonary vascular resistance. So very shortly, the means for therapeutic ketosis are different. We have MCT oil, we have ketone esters, ketone salt, we have SGLT2 inhibitors, and we have also ketogenic diet. So this is my last element, is that we see similarities between the heart failure, so the reduced ejection fraction, and also with so pulmonary arterial hypertension, and as well with Fontan heart failure from the first omics studies. So thank you very much for your attention.
That extent of impact. Sind da noch weitere Fragen dazu? Dann würde ich das jetzt einfach mal für eine Diskussion für später stehen lassen Ich bedanke mich sehr herzlich und würde jetzt Frau Professor Michel bitten, über Regulationsmechanismen auf molekularer und zellulärer Ebene.
Regulatory mechanisms
Frau Professor Michel kommt
at molecular and cellular level in the Fontan cycle. She's coming from Innsbruck, from the clinic for pediatrics, and
vielen Dank.
many thanks. Yeah, thank you very much. Let me just have a look briefly. There is the pointer to click for the next slides. Okay, many thanks for your friendly introduction and for your invitation to be able to speak to you today. So I come back briefly to the so-called ketone-based therapy, and I want to say briefly for us as cardiologists, it's very interesting to know that the SGL2 inhibitors and the NCP acids can have a ketonic impact, and it's very important that the liver is the only organ in the body to deal with a ketone, and the other organs, the brain, the heart, are able to have it as in part of because with patients if the systolic function is still functioning, then we know that the fatty acid processing is increased, and then they don't play such a big role. But there is a lymphatic exchange, and ketones are part of the metabolism. And this is very interesting because this is the patients with reduced EF. We find also in patients with Fontan problems, and we have it found out with our close cooperation with our colleagues in Bad Oeynhausen, and we can see here that it points to mitochondrial dysfunction because there is a transport system that doesn't work as well as it should, and that means that long-term fatty acids, you can see, they don't get into the mitochondrium, and it's very interesting that ketone vessels and NCT acid are not depending on this transporter system. And we looked at the blood of the patients, about 20, a very small study, and it's very exciting that there is a working group from Colorado showed similar result at single ventricular patients, and it's very exciting. And ketose, but the liver with Fontan patients, is it able to produce ketone bodies? The liver cells, they are in squares here. They have different kinds of enzymes. They don't do the same thing. And here we can see how the nutrients are being transported, and we can see whether there is a glucose or not. And then it goes to the central venous system, and that's where the glucolysis is taking place, and it's especially where the fat is being processed. And it could be that it works well, but we don't know whether we have changes or limitations over the entire system. But what's very exciting, what we know, is that most patients, no matter how good we see them, have an increased gamma GT, we don't really know whether they have hypopathy. And most produced still well proteins and also have no manifest cholestasis. But we know, do we have to interpret the cholestasis differently? But the gamma GT is positioned here, where the gallbladder fluid exits, and if they are so-called type junctions are defect, and that what happens with the gamma GT, it's an enzyme, it's positioned here at the membrane, and it's responsible for releasing or and reducing free radicals and to recycle them, and it has to be broken down into the individual parts to make it able to enter back into the cell. And these amino acids, once they have been separated, they also function in a proactive way. And it's very interesting that an increased gamma GT is connected with an increased cardiovascular risk. And it's interesting, this is from a Spanish working group, and one of these 400 patients showed complex heart dysfunctions. And it was very exciting to see also here, this is a cutoff of 60 per liters gamma GT activity. It's very little increase, very small increase from our point of view in order to see the cutoff in the curve. And very briefly to our results, we have individual cysteines, glutathiones, and that can be allocated to further stress, and also endothelial dysfunctions, and in the part of the MET-SO dystasis, that so that we can interpret an endothelial dysfunction. And it's interesting, this is from a meta-analysis from congenital heart diseases, where we had various studies that were used and could be illustrated here quite nicely. And it's very exciting here, the NCT acids that are being used, and they are helping where the oxidative stress is found. And then I would like to leave the information, but we also have the liquid profile of the patients, and we see here the so-called feed map at Fontan patients, and everything that's dark has a higher concentration, everything is lighter is lower, and we could see that the phospholipids, well, first of all, I didn't know what to do with it, but I think you've heard of it. They are also connected to the prostaglandins and phospholipids, and reduced phospholipids reduce the membrane fluidity. And so next to the cholesterol, they are one of the elements and the cells that manage a good flexible barrier function. And the cell membrane is not just made up of lipids, but also of proteins. And I would like to mention two, the syndicane and VCAM. It's this syndicane is very often connected to a so-called glucocalyx. It's a protective layer in the vessels, and blood vessels, and lymph vessels, and lymphatic vessels. And and other forms are adhesion molecules via a mechanical process. It comes to a signal cascade. That's so-called mechanotransduction, and it leads to an increased serum in the blood. And yeah, we only used protein analysis, and when it came to the good Fontan group, we only saw 4 increased proteins, and we are now about to extend it, and we have a more heterogeneous group, and we also found, and you also find it in healthy patients, and it's a so-called endothelial glycol calyx shedding. And the last slide, I mentioned it before, this kind of shedding, this glycocalyx problem, that it's a defect, also described in the lymphatic vessels. It's only a thought, maybe it, what we heard before, 3 years after the treatment, some obstructions appear, and in the lymphatic problems, whether the theory of decompressions, compression of the lymphatic vessels in the intestines, when you can also talk about changes in the system and influence systems in a positive way is one thought. And it's interesting here also that in these days your nice work was published from a survey in Europe. You included 30 centers that deal and treat lymphatic problems, and 14 of 31 centers have chosen dietetic measures, and if it's also, it may be a limitation, but it's still worth thinking about whether it's meaningful afterwards because of their anti-inflammatory impact. So I would like to summary with healthy Fontan patients. You see regulatory Fontan's changes. It's in the energy metabolism, in the oxidative stress. We see inflammation, we see this endothelial dysfunction, and the potential dual role of ketone bodies on the metabolism, and also the anti-inflammation effect, the questions the interpretation of the CGT, whether it is a marker for cardiovascular risk, and the importance of this change, this the significance of altered mechanotransduction at the endothelium. The shear stress can change and epoxy, and so when you have defects, when you have damages, there are further impacts on the fluidity, not just regarding inflammation, but also angiogenesis of the lymphatic vessels. And I think this is a big picture where, with Fontan patients, that we have to take into account into our in order to better characterize the further processes, and also determine risk patients and candidates or for or against the Fontan complications. Thank you very much. Maybe briefly.
Was soll ich tun?
All of these studies, our studies, and they are based on the so-called omics technologies and methodology, and you have the ability to see several patterns. Many thanks, Professor Michel. It was very exciting because my first reflex is, well, what's the egg and what's the chicken? And I'm very confused now because I don't see any perspective where what is the order of things. What is the chicken? What's the egg? Well, that's very exciting. It's a similar situation intrauterine and also when it's intersurgical, whether there is a connection to the development, whether this ventricular development takes place. Well, it always continues, and my imagination was that in the further development of post-fatal hemodynamics, that was be my philosophical question. But anyway, the PLE, we don't have that many Fontan patients, but the other patients use mTOR inhibitors or propranolol, and it's interesting. Maybe we can go in that direction, whether there are other mechanisms that we can benefit from and introduce. Many thanks. I will look forward to the discussion in the next years on different levels. Sorry, Mr. Sänger.
Yes.
Yes, I have a question. I know how we parents think, and what I mean is, what values do you use? Are these general values that the cardiologists use in the clinics, apart from other standard values that they use? So is this something that is part of the blood tests? And do you work interdisciplinary? Second, yes. The pediatricians, and yes, that is very interesting, and that's what's keeping me there. So I'm very thankful for the cooperation with the ATZ. So I talked a lot about the gamma GZ because we always say cholestasis, but we have a general problem. And then, yes, the proteins, cysteine is also a protein, but the transmembrane proteins, we wouldn't do that normally, no. So we have companies that are specialized in this and that have we work with, so that's more sophisticated, really. But so we need to recognize patterns. So if we have several factors for growth, for example, that you use in oncology, for example, so we can say yes. So it's not witchcraft, and we will have more and more techniques and make it easier and less expensive. So we recently met in Oenhausen, and the families said that we go to the pediatrician, then they make blood tests, then we go to the GP, and then we have other blood tests. Then we go to the clinics, and we have another blood test. So we would like to suggest, or maybe a working group to have a general blood tests that are unified in Germany, and that you can enter in the app, and then we have the units. Unified units, so that we have the different, the same references. So some people say that's all nonsense, we can't do anything. Others say this is too expensive, we can't this is not reimbursed by anyone, but people need to sit down at the same table, and this is something that can be adapted and adjusted with time and with experience. So people shouldn't say, no, this is something that we can't deal with. Yes, the experts say, yes, we use this and we need this, and we can evaluate these data, and then we can all work together. Thank you. Yes, briefly, please. First of all, thank you very much, Ms. Michel, for your very stimulating talk. So we can use much of that for basic research. So we need more, but you want the answers already, and I think that's normal. So please, Thomas Sänger just said that. So we need large studies, and we're just at the beginning of that. So I'm not working anymore, so I can only appeal. Yes, that's an unfulfilled dream to have a general center. Thank you very much. David Renaud.
Jetzt geht es nicht Ketone, sondern es geht Updates aus dem Fontan Outcome Network. Und ich habe verstanden, dass das Ergebnisse auch von internationalen Arbeitsgruppen aus.
Okay, super. Thank you very much. So for the second time, literally for the second time, okay. For the last year, for the Fontan-Hearts-Symposium, Professor Jack Rechik came to explain what is the Fontan Outcomes Network. So we will do this year a small update. I am part of the research work group, we are working on the research side and on the research proposals that are coming with the registry. So as I said, Professor Rechik was here, but what changed since? First, I will make a small summary of what is the Fontan Outcomes Network if you didn't see it. So our vision is to improve outcomes and quality of life for all individuals with single ventricle heart disease and Fontan circulation. And we will do it through optimizing longevity and quality of life for individuals with Fontan circulation, with improving physical health and functioning, neurodevelopment, emotional health, and resilience. So what is Fontan Outcomes Network? First, it's a network. So every year, new centers are joining the group. We are currently 38 centers, mostly located in United States, but slowly developing international. Some of the centers that are members are here. You know some of them. But it's more than simply a network. It's a learning network. So first, we are engaging the full community together. So it's patients, clinicians, researchers, all together to improve the outcome of Fontan patients. And with integrated data sharing and technology, support for QE and research. But it's even more. It's so the learning network plus the clinical registry. So care centers are collecting data at specific intervals with consenting the patients. It's fully made around the patients. And then on the second step, we have analysis and learning what's going on with Fontan circulation. Yeah. Okay. What happened precisely since last year? So the first element that is done is that the registry is now launched. We have a bit more than 1,450 patients. We have exactly yesterday 1,481 patients that are enrolled from 26 different centers. The median age of the patients is 14 years old. The main diagnosis is hypoplastic left heart syndrome, followed by tricuspid atresia and DILV. We have mostly 5 teams, so the teams that we see in the literature as to be also very important: liver health, exercise, physical activity, birth control and pregnancy, transplantation, and emotional health. QE project on progress are on the side of exercise and liver health. We are developing also toolkit. And this is what happened over the last year. We had the first review proposal of research based on the registry. We had 17 applications from 21 different institutions. We have 4 proposals that are accepted and 6 that are currently in revision. And why Fontan Outcomes Network matters? First, because care centers that are joining the network take big benefit out of it. There are improvements that will be done thanks. We know that previous learning networks improved quality of life and outcomes of patients. So this is something we want to reproduce in Fontan circulation. We have use of an advanced flexible data platform with analytics and patients assessment, allowing detailed tracking of Fontan care through the lifespan. This is a very important thing, that the registry is not made for a one-time control. This is across the full lifespan of the patient. Access to registry data for quality improvement efforts. Authorship opportunities to publish using more granular registry data. This is what is currently going on with the first research proposals that are processed. Faculty and staff will have many opportunities to serve on various work groups and committees, and participation in a bi-monthly case review conference. So is it only for USA? Because this was one of the big questions last year. No, we have Canada that just joined us with Stollery Children's in Edmonton, so Alberta province. So what can centers expect from the Fontan Outcomes network? They can have, you will need to have support from executive leadership at your center, provide necessary resource to devote to network activities, establish a multidisciplinary team with expertise needed for Fontan Outcomes network, designate one member of the team to be the principal investigator, one member of the team designated as the care center's contact, communicate in a timely fashion with Fontan Outcomes Network, and an annual participation fee to cover the cost. And who should be on your team? So definitely a pediatric and or adult cardiologist treating congenital heart disease and Fontan circulation, an individual with single ventricular heart disease or a parent of a child with single ventricular heart disease, nurse and allied professional health responsible for Fontan care, psychologists, social workers, research coordinator, and specialties like hepatologist, neurologist, radiologist. And to connect with the Fontan Outcomes Network, we have our different emails. And so to thank our main supporters and partners, so Additional Ventures and Congenital Heart Alliance of Cincinnati, and our partners, the National Pediatric Cardiology and Sister by Heart. Thank you.
Thank you very much. If I understand correctly, this is a systemic approach that wants to distribute the information on in the field, in a big field. And my question is, how well do you have the refinancing secured? So my experience is that these projects always have a great risk of refinancing.
Again in English. Well, I was asking simply who is paying for it, because from my experience, it's the great Herausforderung, it's the great risk is not to have an adequate refunding.
It is funded by centers, so this is why we saw that there is a cover fee per year.
Okay, so this is not a problem.
No, in US, at least in US and Canada, was not a problem.
Okay. How much it costs is your question? For the membership.
For US centers, this is $15,000. But I invite you to contact directly Fontan Outcomes Network to see what is possible for European centers.
Yeah, beantwortet. Yes, answered. Yes, please.
If I heard well the question, do you want German centers to participate? Yes, obviously every center is welcome. Currently, no.
Can you repeat this a little bit louder, please?
As we cooperated with the pediatric medicine in Europe and America, we saw massive problems in transferring data from Europe to the US. We failed in giving data, German data, to that registry, Pediatric Action Network, because of that. So there might be big problems.
This is indeed one topic that when centers from Europe will want to join Fontan Outcomes Network will need to be considered about the different laws about the data privacy of health data. Yeah.
Thank you. Thank you very much. Ich glaube, wir haben die erste Kaffeepause erreicht. Ist das richtig? Dann darf ich Sie nur einfach zum Kaffee einladen und wir werden uns 2 Minuten, bevor es weitergeht, wieder hier vorne hinstellen und Sie alle bitten, wieder zu Ihren Plätzen zu gehen, sodass Sie jetzt erstmal freie Zeit sozusagen haben. Vielen Dank. Sehr geehrte Damen und Herren, liebe Mitstreiter, liebe Gäste,
Dear ladies and gentlemen,
wir
dear
wollen
guests,
so ein bisschen
we would
weitermachen
like
und
to
ich
continue,
würde Sie einladen,
and I would like to invite
in
you
Richtung
to
Ihrer Plätze zu gehen.
come back to
Danke.
your seats. Thank you.
Vielen Dank.
Yeah, many thanks, and I'm very much looking forward to introduce Professor Anselm Oelwig from Kiel. Dear Anselm, I'm very happy that we always meet at these events and have exchanges, and many thanks for speaking about long-term results of Fontan circulation, present and future, and also about the elements of the Fontan Rorus. Many thanks, Ralph, for the introduction and again for the invitation. It's always great, this meeting, and another fantastic program this year. I have to go back some slides. I was asked to talk about the long-term results, present and future. And if you talk about the present, then a short look to the past helps. What is the situation without medical therapy for our patients in the univentricular circulation? And we know that the prognosis for survival is very bad for our patients. With the left ventricle, it's better than the right one. But if a singular heart chamber, but then a necessity for treatment is obvious. And Francis Fontan was the person who prepared what we call Fontan circulation or surgery, and made the connections of the venous system. And at a further development, what he introduced as palliative treatment, and the introduction and establishment of these therapies, of Fontan therapies, led to a situation where today we can offer our patients a perspective, a prognosis with survival curves that show that about 80%, perhaps even more than 80% of the patients reach the adult age. Those who operated on 20 years compared to today is probably even better. The situation, this is data from Australia and New Zealand from their register. And our data in Kiel shows similar survival chances, and we have an atypical share of patients with a left heart syndrome. If you look further, and we had data that was published in the Royal Brompton Hospital surgery, and we can start at the age of 35, not 35 after the Fontan completions. This is the survival curve in the population overall. The patients with modern technologies, and where you can say that about 10% mortality over 1 decade. And then from these studies, if you look at not the mortality but morbidity, so what is left in terms of disease, what can be monitored. We have complications that we talk, rhythm complications, and necessity for pacemakers, and lymphatic failure, and increased or decreased performance. And if you consider all these events, you have freedom of complications that is about 20%. So mortality is one problem where we have made a lot of progress over the last decades, but you can still see mortality and if you use these long-term studies and in order to deduce a survival curve from it on the basis of the data that we have today, then you get about a 50% survival rate, and with the complications, obviously, a somewhat worse curve when you, especially when you enter the fourth decade, where there is very little need for treatment. And if you look at these statistics where you have severe events, then you know that you need treatment as a Fontan patient. It's not that the Fontan circulation is a panacea, and but you cannot. It wasn't established as a cure for the patients, but it was a therapy for cyanosis, where you first try to have to separate the blue blood, and at the time they did not consider the long-term problems that we are doing now. And due to this palliative Fontan circulation, we have all the follow-up systems. We heard about venous pressure, and also on the lymphatic side, increased pressure, things like chronically reduced circulation, and ultimately the entire body is involved when it comes to the impacted by the follow-up effects. And we can ask ourselves what we are doing at the moment. So how can this circulation can be maintained on a good level? How can the prognosis of Fontan patients be improved? And also, when we talk about surgical measures, primarily, what's important in this context is where we see the most dramatic impacts over time. Most of these patients have residual pathologies, meaning we have patients with Fontan circulatory problems that have obstructions somewhere in the circulatory system, here in the aorta, and here you can see the stenosis, and here also when it is the insufficiency of the valves. And so the treatment of such pathologies is an essential strategic element for the improvement of the long-term situation. We talked about diastolic functions before, and how much it can be influenced by a ketogene diet, but it can also have an adverse impact on the Fontan circulation that's recognized and acknowledged. And these are post-load increase without stenosis and aortic. This is the very close correlation, where we have reduced the diastolic ventricular functions early after the Fontan repair and aggravated by abnormal afterload. And these are data that I've shown before. If you look at patients that have no measurable difference, but show abnormal configurations and unusual curves compared to a normal aorta arch, that these are abnormal blood flows. And if you look at these abnormal functions and accounted take it into account, then we see that with these patients, the muscle mass is increased independent of the pathological fluid physiology, that there is a link between these abnormal muscle mass, and so there has to be feedback with the surgeons when it comes to anatomical functions. It's a strategy for the improvement of the prognosis. So remove residual phenomena, and we have to think very early on how it functions and what the influences the blood flow. And diastolic heart function is very important here, but also what happens on a pulmonary level, because there's always a bottleneck in the circulation, and it has to be taken into account. We talk about diastolic functions, and we have also the heart failure with the preserved injection function. These are ventricles that can contract quite well. And this a group of patients from the adult cardiology can be seen here. When you have a high physiological load, then the pressure increases, and the same happens with the Fontan patient. And it can be quantified, it can also be investigated, and it can be a limitation problem for the blood circulation, but also an abnormal lung function or lung structure, pulmonary vascular changes in the lung due to the abnormalities of the blood circulation. And this is what you have to differentiate, where a patient is limited in his physiological performance. This is obviously a problem, and with whether you have to see whether the lung is a problem or the diastolic function of the ventricle. And you can best approach this problem if we do physiological investigations of the patient, also by measuring of the central venous pressure, and then, if necessary, due to with a combination of measuring the venous pressure and the venous pressure. And we know some patients the pressure rises faster, in other groups not so much, and these two groups differentiate. And if you then have the load in the vein, whether you can detect from the heart catheter whether it's a combination or there is a leading problem, and you can analyze the gradients in the diastolic blood pressure in the ventricle, and can see whether there is a problem on the lung or the heart. And for both entities, we can today develop local therapies. So individualized therapy, the inclusion of load physiology, these are aspects that we have to consider. And then what's quite important, when it comes to congenital heart disease, is what influences the prognosis. And we can see here with Fontan patients where they are in, when it comes to a low tolerance and prognosis, they are at the lower end. They have limited physical performance abilities, and it's important when it comes to the prognosis. You see here the survival curves. These are historical data from the Brompton Hospital. These are the most important indicators for survival, and how well it can be influenced or how bad. You can see an overview from Australia, from Rachel Govina and her group. They said, let's have a look what heart insufficiency medication can do when it comes to intake of oxygen. You can see when it's best, you can see it's sport, physical strain, an increase leads to an increase of the performance ability of the patients. And not a drug, no medication can achieve that as just like physical activity. And physical activity is also something that we have to focus on, especially and when it comes to overweight. It is associated with physical inactivity, and overweight increases very strongly already 5 years after surgery. And the body weight has multi-factors in many negative aspects when it comes to the health of the lung, the breathing muscles, and the heart muscles, and the multi-organ functions. We can see also aspects like liver cirrhosis are not obvious in this trend, but hospitalization with leading to hospital due to overweight are quite increased with less physical activities. And so we give to our older patients the recommendation of physical activity. So the proactive actions is important in order to keep the Fontan situations as stable as possible over the long time, meaning we also have to look on other organ systems in our care, and that's also quite usual. Mrs. Michel also showed it in her presentation that there are new diagnostical knowledge, and when it comes to the liver physiology, and it's also and a way to show the patients how we have, for example, here a 30-year-old patient with a hypoplastic left heart syndrome, and without that lead to increased venous collaterals and an improved cyanosis and performance. And the post-care, they also developed a tumor marker for a liver carcinoma, and this was diagnosed. And so this is the final stage of a Fontan-associated liver disease, which leads to a worse circulation situation. We know that there is this liver cirrhosis, that it progresses, that it's being diagnosed at older age more often. We also know that it's important to investigate for these effects in the post-care. And we can, of course, do a lot with the lab diagnostics, but we don't know how to include this in the clinical decision making. It's a big problem, and we also don't know when and how the liver health and also the health of other organs can lead to a situation where the Fontan circulation can lead to an indication for the heart transplant. And so we don't really know on how to deal with these patients in a unified strategy. Those who it's easiest with patients with a ventricular aspect function, and where we have to then decide for transplantation. But if we have a patient with a good ventricular function and a right heart disease, they when they develop multi-organ problems, whether we have to go for a heart plantation or even, in the worst cases, heart-lung transplantation. These aspects we have to include in our long-term care, and we will also see more and more patients where we see after you care for them over decades, you think now the time has come for a new a circulation situation, meaning we have to consider replacements, and we always have patients when it comes to a multi-organ disease that the patients are too weak, the disease is too far progressed in order to give a realistic prognosis by way of transplantation, transplant. And so we can see now mechanical circulation support systems to the for the preconditioning that replace the Fontan circulation with a right ventricular pump chamber that can be introduced in the system, and then pump into the lung in order to improve the circulatory system. And it's what it says here in the Berlin Heart brochure, the replacement of the right ventricle, the missing right ventricle, in order to give the patient time for this preconditioning, which then leads to a transplant. These are data that I received. Mr. Wehner and Mrs. Sänger asked me to show this new therapy. This is a venous cannula that is designed for Fontan patients. It has two parts, and the blood is removed in a T form and via a cannula into the lung. And so we revive the missing right heart function of Fontan patients to build a bridge to heart transplant. So these are patients that were not that were diagnosed accordingly. It's 18, 19 years old, PLE, 10 of 13 patients, and kidney disease of about by 50%, and poor performance, physical performance ability about 20. And so the complete picture of Fontan failure, and 11 of 13, if I understand the data, were treated with a special venous cannula, and two with a traditional system. And we can see here 3 patients died via the cannulus, venous cannula way. 6 could be successfully transplanted, and here we see different cannulas that probably will recover regarding their organ function. And of course there are successful case reports about this. They're being they're available on the internet or YouTube, and also from Munich, that give the complete picture of the Fontan failure, and Mrs. Fiota presented it this morning. And this can be reconditioned via the Berlin heart cannula. This is the mechanics with the batteries that drive the pneumatic pump. And this boy has been transplanted successfully, and we hope, of course, that this the spectrum, this therapy will increase the spectrum of therapeutic possibilities. So the long-term prognosis, there are possibilities for further improvement if there is an early treatment. The therapy is individualized, and the physiological foundation is good. Proactive health is quite good. Sports, no overweight. Structured, specialized, multidisciplinary care is important. Mrs. Michel also mentioned it. It's important that we get together in multidisciplinary hearings, and we need, of course, the support, and also palliative medicine plays a role here. So there has to be individualized decision making when it comes to mechanical support. And that is my presentation. Many thanks.
Lieber Anselm, vielen herzlichen Dank.
Dear Anselm, many thanks for your very precise description of the long-term problems and also the challenges that we are facing. Are there any considerations on your side? If you don't have any question, I think we will then have the discussion at the end where everything can be considered, and there will be a chance for a common discussion and asking questions. Many thanks.
Ich möchte gerne Frau Kollegin Dori aus
would like to ask
Herr Olfe vertritt sie. Habe ich das richtig
Dr.
verstanden?
Olfe, who is replacing Dorothee Becker.
Vielen herzlichen Dank, dass Sie gekommen sind. Thema geht in die gleiche Richtung. Nachsorge und Therapie bei Failing Fontan.
You're going to talk about aftercare and therapy for failing Fontan strategies in Hamburg. I'm not Dorothee Becker. I am Jakob Olfe. I am also from Hamburg, and I would like to talk about certain research and insights that we have done in the last year. So I'm very happy to speak to this renowned group of people. So more Fontan patients survive, and more Fontan patients develop failing Fontan. So we have 40 years of life and 50% of failure. It's very difficult to analyze. So this was death, a plastic bronchitis, transplant. And it always depends on the Fontan type, but it's 40 years and 50%. At the same time, it's not easy to define what is failing Fontan, what is a bad Fontan, what criteria define a bad Fontan. So if we start from the beginning, where does it start? Where does the Fontan turn bad, and what are the first symptoms of that? So many intelligent people from the research world met, and they tried to find a common language about this. And they wrote a consensus paper, and without having to read it, we can see that it's very difficult, very complex. It has not become easier, and it's a very, very complex disease which has many different treatments. I think we agree that we have different mechanisms of failure. We have the circulatory failure, we have the pump failure, we have the left and right fails. We have problems with the vessels. We've talked about this. And then we have arrhythmogenic failure, and then the end organ damage, liver or renal disease. So that's superfluous to say that, but every failing Fontan needs a different treatment strategy. Everybody knows that, but we have to underline that. So if we look at the pump failure of the system, ventricle, things have changed in recent years. So new treatment strategies for ventricular pump failure have revolutionized the market. And we have Entresto, the Valsartan, and others. So they have become the top medications very quickly, and there are the fantastic 4 medications of heart failure treatment, and the single ventricle world is very enthusiastic about this and will be revolutionized by this. So this is from the Department of EMA. We looked at the single ventricle patients and the TGAs and looked whether the Fantastic Four medication helps, and it does. From the different classifications, the things could be improved, and we have a significant improvement of NT-proBNP, especially in single ventricle patients. In the comparison of the effects of therapy of NT-proBNP in patients with single ventricle and patients with TGA. Of course, there are many studies from all over the world which speak a common language. So the medications haven't been on the market for a long time, but the tendency is that they seem to be really helpful. And this not being enough, the next players around the world. This is, was published a few weeks ago. The original article. So there's a hope that we will have the Fantastic Five. So we have a diastolic failure. So we hope that this medication will arrive in the ventricular world. So summarizing, we can say that, and this is new. So we've worked with medications that had no evidence. So we will have 2, maybe 3 medications, new treatment strategies that are available to treat single ventricular failure. Physical activity is a major contributor to Fontan outcome. We have known this for a long time. It's even more important than the basic condition of the patients, and we asked how much exercise do Fontan children's actually do. PAS, physical activity and sports, and then we also have a study from the Robert Koch Institute in Germany. This is the largest cohort analyzing all aspects of life in children, amongst others, physical activity. So we know how much physical activity the different age groups in children actually do in Germany, and we store this data, and we asked the same question in the cohort of the Fontan children. And here we have 2. So if we look at it, we see that in the lowest part of the physical activity, so who is doing 60 minutes of exercise twice a week, and the Fontan children do 3 times as much. So at the end of the range is people who do 60 minutes every day. So it's the same in Fontan children as in healthy children. So we do have Fontan children out there who are actually doing the right thing when it comes to physical activity. So we need to make sure that Fontan patients, children and adults, do enough physical activity. So I think we have a recognition that the Norwood 1 operation is not good for the heart. So we know that the heart-lung machine and the intensive setting, all that is detrimental to the Fontan heart, and we try to prevent that. So we had the Giessen-Highwood procedure that made it halfway through, and now we have no Norwood, no hybrid procedure. Dr. Strunch developed this, so we've been using that in Hamburg quite frequently, and the principle is that we have a stent, and then the flow is blocked by the. So we can have we don't need an operation. So we have the vascular plugs that can be purchased on the market. So these usually plug this and close the system. In order for that not to happen, we cut a little hole in the plug, which is manual work, and that creates a constant flow and reduces the flow to the lungs. And this means that the children have a very good outcome. We don't have scars. So we don't have a bypass, and the children drink after 4 hours. They're able to drink from their own bottle. So this has a certain elegance to it. Of course, we had a learning curve and theoretical. In theory, we could do this also in other instances. And another advantage is that we can decide in favor of this procedure, and then along the way decide for a different kind of procedure. So we can prevent the surgery, and we can opt for interventional interventions. But still, we have to decide in favor for heart transplant in other cases. If we have liver disease, for example, or other indications, then we need to think at least of a heart transplant. We know that we have a waiting list mortality in patients with a congenital heart failure, because it also depends on the body which is around the heart. And we've seen some data from the cannula of the Berlin heart. So I'm skipping this. So, and here I have some data. The data that we have so far is more or less promising. And I can report that we have one more patient on the list that had a successful transplant. So this is Emil. The family allowed us to show this. So he had the full failing Fontan. He couldn't walk anymore. He came in the wheelchair to my office, and now he is actually playing football. And he is he's playing against Tim Melzer. 1-0. Tim Melzer is a famous German chef, and they won against the celebrities. So it seems to be working. So you can take the patients out of severe Fontan situations. So we do hope that the waiting list mortality is going to improve. So what can we say about the future? So we have a cardiopulmonary support device, which is being developed in cooperation with a Swiss clinic. There we have an implant in order to pump the blood into the lungs. We have first studies in the pipeline with animals, and in the long run, we will have the option to be less invasive. But this is very much into the future, and what we actually follow in Hamburg a lot is the tissue. So we use stem cells to produce cardiocytes, heart tissue. And what we've done is that together with the pharmacologists in our center, we developed a subpulmonal structure that contract spontaneously, cardiocytes, and they are very small in the structure yet, but so if we set this up in a solution, then they expand in space, and we can pace them in their speed. So that may be the future, so that we have natural cardio channels that may be able to pump the blood in the right direction. So there is some light at the end of the tunnel. So each patient, each Fontan patient needs a different transplant strategy. We have new treatment strategies available to treat single ventricular failure. Physical activity is a major factor in preventing bad outcome in Fontan patients. Neonatal surgery can be avoided, and the heart can be protected. And the waitlist mortality in failing Fontan patients is still very high, but hopefully it can be reduced. And new strategies are in the pipeline to treat failing Fontan. And maybe we will be able in the future to support them even better. Thank you very much.
Herr Olfe, vielen, vielen herzlichen Dank.
Thank you very much,
Ich freue mich,
Dr. Olfe.
dass es immer wieder neue
I'm happy to see that there are new visions on the horizon, mechanical, methodical, in order to prevent certain statuses. So as far as I understand, we are going to discuss this at the end. No, but if you have immediate questions, if not, then I would like to postpone the discussion about this until afterwards. Thank you very much.
Okay, the next topic relates to the Post-Fontan checkup in the Heart and Diabetic Center in North Rhine-Westphalia, what can be reported. And I call here Dr. Tobias Hecht. Many thanks for replacing your colleague. Well, good afternoon. I'm Julian Fecht. I replaced Mrs. Bruce, who fell ill. And unfortunately, I didn't have much time to prepare myself, so please consider this. But it would be unfortunate if we would lose this presentation and leave it out. So Fontan patients are our daily bread in our center. Also, Mr. Olfe talked a lot about things that I don't want to mention in particular. Also, this is the basis, the foundations of the Fontan cycle, as we can see here, with the bigger problem areas, especially when it comes to the mid and long-term development. Why are we talking about it? Why is the checkup of Fontan patients so important? Why do we need to improve it? It's not just a problem in Germany that Fontan patients are being presented to us as too problematic and too ill. Also in other countries, you can see that about 40% of Fontan patients are seen for initial consultation and by an advanced heart failure team, and that could also influence the success of the heart transplant. And we, of course, are working on the process, meaning we start working with pediatricians in order to consider their opinion. We talked about the Fontan cycle that can and its limitations that can be on various levels. First of all, the ventriculary functions, the heart functions. It can be valve insufficiencies. It can be the cardiac failure, the pressure, the systemic venous return, and problems in the pulmonary circulation and in other organs, the liver, the kidneys, and lymphatic problems. Well, which long-term problems do we see? We've heard it before. There are different problems. They are quite complex. They can affect different organ systems. They don't have to appear at the same time and not with everybody, but they are very individual. And it's very decisive for the life quality of the patients that these complications and these problems are detected at an early stage and treated early on. And for this treatment, when it's a multidisciplinary target is necessary in order to discuss the therapies and to find out which therapy is the best for the patient and least invasive. And also, let's not forget, I think this is also where I agree with the parents. It's about the patients and the parents and the psychosocial care, which can lead to long hospitalizations. The long-term problems, we mentioned it, bronchitis, plastica, the different algorithms, and from also other centers that have been published, and mostly at the beginning there is a normal clinical checkup to evaluate the liver function, the clinical state, following with lab procedures and image procedures that I don't want to mention in detail. How do we do it in the HDZ? Normally, well, since a couple of years, we try to collect data on our patients. It wasn't always easy and do it in an objective way at our center, and that led to a situation where the patients that we look after in the center that were sort of lost from our view, and we are trying now to see which patients we have, where we are with the patients, what kind of investigations do we have to carry out, what are the short, mid or long-term problems that we have to tackle. And the anamnesis is clearly in the focus, but also a lab chemical aspects, so that we can establish this algorithm. And that means there are measures of a pre-Fontan surgery and MRT, heart catheter investigations, and also lymphatic vessels anomalies to make it more visible, and then other procedures. Then the first investigations are foreseen at the age of 6 months and 12 months. There are very few long-term problems that we can detect after 2 years. You can see it here well. We have a bigger spectrum of checks, and then also load function checks of the lung, and how to find out how objectively the load reception is of the parents, the patients, and that gives us also a good initial value in order to make changes more visible. over time. And what we also do on a regularly basis is ways to make the liver anomalies more visible because it can lead to an increased carcinomic risk. And which lab checks do we do in our center? Of course, mainly organ parameters and that are influenced by the Fontan cycle, meaning liver function parameters, bilirubin, cholesterinase, and possibly also coagulation factors, the kidneys, creatine, urea, cystatin C, then the proteins, electrolytes, coagulation, lipid status, and we also investigate the vaccination titers in order to find indications for the loss of protein, and also in also possible pre-vaccinations or vaccinations that happened before. They can possibly limit it. Therefore, we include them as well. And then, but in patients with incipient failing Fontan, we also look for HLA-A screening and antibodies. And because we want an early sensitization of the patients, meaning within the framework of transfusions or homographs that were used in previous cases. They can be in previous pregnancy, for example, there can be antibodies that can influence or negatively influence the surgery success and the transplant success. So the Fontan work in our center, of course, it targets always to detect the complications at an early stage and find a therapy. That means there are different problems that can arise as cyanosis, collaterals, and then the question of an interventory occlusion with catheter labs. And we also look for interventional therapy options when it comes to lymph vessel and abnormalities, and there are only very few centers that can offer these interventional therapy options. When it comes to loss of protein, that can be lead to a different dietary treatment, and these are things that we include. And it's the take-home message that we would like to give you. It's so present these patients to super regional hospitals or centers. We see very often that we get the patients too late, and then the transplant is influenced negatively if we come too late. So advanced liver dysfunctions, and this is also in the direction of the catheter intervention, and also the organ failure. That is a process that can last several months or several years, and it's very difficult then to intervene. And now, what is the practical side? We have a patient here with a PA stenosis, and this was then there was a dilation and a stenting. Many patients have show a lot of collaterals due to the collateral closures and because and a further problem of the patient that was submitted, there's the notice in the Fontan tunnel. It's the target here that to keep the cycle alive, and also any increased organ pressure is to be then corrected with a then up and improve the fluidity. And what happens if the problems cannot be corrected? How can we act then? And so then the question comes up of the HTX evaluation. First of all, we try to give a picture, get a picture of the patient. Therefore, we need a lot of pre-information. We need lab investigations. We need imagery of the patient over time, and we have to see what kind of procedures have happened before. Were there perioperative causes, complications, previous interventions, and somewhat in the direction of the sensitization. Then, when it comes to the indication, we have to see whether the problem can be solved by therapy or not. Which is the risk, the individual risk profile? Do we have a complex anatomy? Are there pre-operations, or is there end organ damage? And then there is the initial presentation of the patient at our center, where we do a multi-organ screening for the exclusion of the contraindications, and then a detailed discussion about the transplantation, covering all aspects, because it's very important for the parents, and to show them that we are coming into this, we're going into this direction, which is a big step. Is the patient an HTX candidate? That depends a lot of factors. Are they reversible? Are there any signs of the negative influence on the post-transplantal course? Is there an increased lung pressure? Is there, what about immunology, HLA antibodies, sensitization? Are there any latent infections? And also the psychosocial situation, the compliance, the adherence, the life situation, supportive environment, and the resources have to be considered. And as Mr. Rolf already said, we also only have the possibility to bridge patients in order to prepare them for a better transplantation, to improve their situation. And we try with these systems to relieve the load of the organs and get a better parameters for the organs. There are different systems that we can use for the left heart, and also the Fontan cycle, and or both even, where you have to say that both appear very rarely together. And our experience with Fontan cannula, and they are quite limited. And at the moment in our center, we have 2 patients that have these Fontan cannules. And what is the target here? Well, we try to relieve the pressure, and also then alleviate the lymphatic system. Whether it will be successful, it's difficult to say at this point in time, because we don't have enough experience yet in our center. And with these cannulas, you can see that the patients will remain outpatient in an outpatient state, which is difficult for the families. And we are trying to make the patients more mobile. And there are centers that release the patients to their homes with their cannula systems. But it requires a massive pre-work in order to include everyone, the emergency services and the general practitioners and schools, etc. Of course, we can prepare them, and but everything else, the entire school sector, the whole environment is not considered, and it's a huge effort to manage this. And of course, it's only possible in clinical center where the patients are looked after in the environment. And of course, it's difficult for us if these patients are living in other cities that are, more than an hour's drive away. And the cannulas, Mr. Olfe presented it already. There are not that many patients who have it. And it's about improving the organ situation. You can see a patient with a very complex anatomy that we also treated in our center, and with a heterodoxy syndrome and dextrocarbie. And it's a lot of pre-work is necessary if it comes to a transplantation. You have it leads to long surgical times and very complex development. Dear colleague, I can give you the microphone in the meantime, please, because
Genau, in Europa sind wie gesagt nur
in
33
Europe,
Patienten,
we only
Patienten
have
können innerhalb von 6 Monaten transplantiert werden.
33% of
Die
patients
Wartezeit in Europa
can
viel
receive a
länger.
transplant. The
Zusammenfassend,
waiting
der
times in
Verlauf ist
Europe
sehr
are much
individuell bei
longer.
uns in Deutschland. Probleme
To
können unterschiedliche
summarize,
Organsysteme
the
auftreten
course
und
of
sollten
Fontan patients
frühzeitig
is
erkannt werden.
individual
Das
and
ist meine
very different.
größte Take-Home
Problems can occur in different organ
systems
systems if recognized early, and improvement can often be achieved. Regular and close meshed progress assessments are important for this. These should be multi and interdisciplinary, and the likelihood of clinical deterioration over time should be discussed with patients and families.
Was ich aus meiner Sicht ganz wichtig fand, ist, dass Sie sehr früh dafür plädieren, die Familien auch in die Überlegung als solche einzubinden.
So, what considerations do we have to make in order to improve the family situation? Many thanks. And I would like to then call Mr. Alcázar. I understood that he has a very special dual origin on the head of the special area to the heart surgery clinic in Erlangen, but also a pediatrician cardiologist at the Paracelsus clinic.
Yes, thank you very much for coming and for talking about epicardial support for Fontan patients. Thank you very much. for your kind introduction, and thank you very much for the opportunity to present a option for mechanical support of the Fontan, of the heart, which may also be interesting, very interesting for Fontan patients. Okay. So I'm going to talk first of all about the heart insufficiency in general, then about the specifics in Fontan patients. That's a lot about the this dystonic heart insufficiency. Then I'm going to explain why it is important to find alternative options for the mechanical heart support, especially in the group of Fontan patients. I'm going to talk about the system that we have developed. First of all, insufficiency, heart insufficiency can be comes in two types: systolic dysfunction, and the heart is not contracting correctly, and then we have less ejection, and that's to the detriment of the heart function. Of course, we can also have a diastolic dysfunction. That means that the heart relaxes. And if it doesn't, if the relaxation is not correct, and the ventricle is not working correctly, then I have a diastolic dysfunction, and this means that the pressure is rising, which causes a lot of problems. So the diastolic dysfunction with people that have both sides of the heart working correctly is not a big problem, and they will develop a disease after a very long time. So what's the difference between the systolic and the diastolic dysfunction? So we have many different reasons why we have for the causes of this dysfunction, and this means a very complex mechanism that causes a fibrosis in the heart, and that's a completely different material. So the heart turns stiffer, and that leads to a diastolic dysfunction, and that can also lead to a systolic dysfunction. So we have different reasons. Myocarditis or heart rhythmic failures, but if we look at the causes of Fontan patients, in Fontan patients we have a very important reason with the right ventricle. So the systolic dysfunction has another mechanism, which is the activation of so that's the failing Fontan, so that the circulatory function is not complete. So this is also leading to an insufficiency. So in Fontan patients, we have the failure leading earlier to a dysfunction. So we have the systolic dysfunction of the heart, and this leads to the fact that the pressure is rising on the right-hand side, and over the course of time, this leads to a rise in the pressure in the pulmonary arteria, and this means that the lung vessels are changing, and then we have a permanent hypertony and a dysfunction of the Fontan circulation. So what does this mean? So In most cases of the failing Fontan symptoms, we have a rise in pressure. It doesn't even have to be high. So in the Fontan circulation, and then we have a venous pooling, and this means that we have a relative volume deficiency on the right-hand side, which leads to functional heart failure. Then we have microembolisms in the heart, which leads to an increase in fibrosis. And we have micro heart failures. We also have arteriovenous collaterals. We have loss of protein, and we have many other factors also, and the immune system also plays a role. But we have the diastolic dysfunction in general. And with the Fontan patients, we have an increased probability of developing high-grade heart failure that can only be treated with a transplant or mechanical cardiac support. In case of the mechanical cardiac support, we have the bridge to recovery, a bridge to a transplant, or a destination therapy, a permanent support. There's a good study, a good paper from of 2019 with the largest cohort of Fontan patients, 55 patients from the US. And here we can see relatively clearly that only a very small portion, 15%, after a year are still connected to the machine. The rest could be transplanted, but a quarter of the patients die. So we have 5% that recover. So this means the heart support is good, but we still have problems. Where do we have problems? We have a blood contact, a direct blood contact. So we have a bypass system, so we have a pump, and the pump accelerates additionally to the heart. It activates the blood system, and this leads to embolic situations. So the idea is to have an additional heart muscle. So you have a membrane and an artificial muscle outside of the heart. So it works, it supports in the diastole and in the systole, both. And we realized this with a dielectric elastomer diaphragm. There we have a certain tension, and that accumulates power and can also give up this power. And it took a while until we could actually create a functioning pump, and we needed to find out whether it actually works to support the heart from the outside. So is it enough, and how much power, how much pressure do I need? So 10 years ago, we started with a computer simulation model for the heart. We were supported by mathematicians, and it took quite some time until we had all details in place, and then we could say that we have the heart insufficiency of 45, for example, and we have a higher pressure of 15 millimeter Hg. So we looked whether when we support the systole with 5 mmHg, and we have 62% of support, but we still have a relatively high systolic pressure. On the other hand, we only needed 4.5 millimeter Hg in order to reduce the pressure to 6 millimeters Hg, but there so only half of the systolic pressure is needed in order to have the result, like a 90 millimeter Hg. And at the same time, we have a low pressure. So at the end, we have the best solution by have the diastolic pressure, and we have the heart pressure, and this is successful for the diastole and the systole. So this is not new, by the way. So in the 60s already, there was the idea of creating an outside pump around the heart, and there are one or two companies trying to develop this for the market. There are research groups. The difference to our group is that we have less tubes, and it is mechanically easier. So our system makes a lot of sense, probably for Fontan. So here we see the first experiments, how we realized this external pump. So this is an artificial arrangement. This is a dummy, and that's we have a we tried this out with animals. We used this on animals. And here you see how we have an animal heart, and we have a heart attack after. So we caused a heart attack, and then we have a significant reduction in infarct side, heart attack side. In Fontan, it is obvious that it makes sense to use this. We haven't used this as yet. So we're still at the beginning. We have the principle. We could prove that in animals it works, basically. Now we are going to try to use it on larger animals. And so going back, why does it make sense to use it with Fontan patients and use it as a test system, establish it as a test system? Because we only support one ventricle. So if we pressurize, we don't comprise the right ventricle. So this makes it much easier to make predictions. We can effectively treat the diastolic dysfunction. So we don't only treat the heart insufficiency problems, because if we did that, we could probably also treat failing Fontan, and we don't have direct blood contact. So summarizing, we could say that the diastolic dysfunction is central to heart failure in Fontan patients. Permanent mechanical support is not an option due to high mortality rate with the traditional mechanical support systems. And the epicardial support through dielectric elastomeric membrane provides an early therapy approaches and could prevent heart failure and failing Fontan. And in the long run, we might be able to help these patients. Thank you very much for your attention. I'm happy to take your questions.
Vielen Dank, Herr Alcázar.
Thank you very much, Mr. Alcázar. So we said that the discussion as such is going to take place afterwards, but if there are any pressing direct questions, please go ahead. Yes, this is a very interesting approach in its early stages. So this was a computer simulation model? No. So we used a rat. But the first section was a computer simulation. Well, we work to track. 2 tracks. So we said it's important to have a simulation to optimize it in order to understand how to proceed, how much pressure we need, when we have to go in with it. So we have the systole, we have the distole, relatively large, and it helped us. So were the results of the animal testings published? No, not yet. Yes, very interesting. In the cardiac cycle, she said that you have end systolic and end diastolic support. I didn't understand that. So the diastole, that's an active process. So there's an active construction of the heart massive. So why don't you support early in the diastolic process? Yes, well, so we researched a lot in order to find that out exactly. So we are trying with the diastole in order to find out with the rat hearts with a heart attack. We didn't have a problem, but now if you have heart rhythmic problems, then it's difficult to find the right moment. So, so there are small differences, but they don't. So we start with the diastole, and with that we start the whole volume. So the left ventricular, and this is something that is comparable to a healthy heart. So it's early in the diastole process. So the pulling would be early diastolic. Yes, yes, but we would continue until the end diastole. Thank you.
Now I hand the floor to Mrs. Sänger, and it's about well, all the consideration when you have capacity and incident, you want to have exact figures, and it's about a report on the patients with a one-chamber system in Germany. So how many Fontan patients do we have in Germany? Many thanks. Many cases, professors and surgeons are calling me, Mrs. Sänger, have you received any confirmed figures? And I must say, no. Every journalist that we had could convince on the situations of our children, and the question is always how many are there in Germany, and we don't have any answer. And for such a modern country, it's not a good starting situation in order to help the Fontan patients. So the exact number of people in Germany with a one-chamber heart is not exactly known. The estimations, Professor Kammer, you mentioned it as well, about 5,000. This is the assumption, but we don't know exactly. And when there is the 2 books that are available, it's about the heart fault is explained exactly from the perspective of the sibling child once the diagnosis has happened during the pregnancy. And the book helps a lot of families that decide on having a child. And anyway, this reception at the publishers, on the occasion we founded a working group in order to get precise data. Professor Lars Timm has not arrived yet. He's coming from Hamburg. He will introduce himself later on. It's about the founding centers. Rolf Stubert former CEO of the EKK German Federation and publisher of World of Health Service. He is a big supporter of our parents, and we thank you and are grateful to you that our health insurer financed our visit to the US with our daughter, a wonderful person. And he said that he has to always make sure where he can help. And he always says that our parents, our children and their siblings are worth any help and support. And then Timmerly Gärtner was helpful with research on relevant ICD codes, and she can unfortunately not be here today. And Professor Grabitz, he is a cardiologist and researched the ICD codes, and from cardiology we always need the support. Via the contacts of Mr. Rolf Stuppert, we could contact the health insurers and in order to find case figures. As you see, I don't have it on the screen, but we started the work and we won't give up because we have so many problems that we have to deal with, and we will continue tackling them. And if you have any ideas, we are open for support. But one example we can give you of the health insurer in Hesse, from 1,737,000 insured people, 280 affected persons were identified. There was also a number of 370, but we assume that the relatives have increased the number of cases, but you cannot really use it for a calculation. We are still at the beginning, but we don't give up. The initial data are supposed to lead to a care situation, a good overview of the care situation of the patients in Germany and their needs. In order to improve the data collection, it's necessary that many Fontan patients and their families get organized in our group and then use the app that we will present in a moment. In order to use this app, well, that also gives us the possibility to better detect the number of affected people. At the moment, we have 500 families in our group, and if you look at the Fontan register of the US, I think 1,400 or 1,700, so 500 in Germany. In our group alone is quite a good number, and it will give us a good chance to collect a lot of data. And here I would like to then introduce Professor Grabitz and Stefan Raab. He really is called Stefan Raab, like the famous person, and but he was recommended by parents. He is really called Stefan Raab, like the famous television moderator. But anyway, the comedian. And but I would like to introduce you, Professor Grabitz. Yes. So the app gives us a lot of possibilities, and Stefan is coming up. But this data sheet, if we look at it, that tells us which blood values are important for Fontan patients, where we say these are important for the cardiologist and for the cardiovascular clinic. Then we can have a common basis for all of Germany. And of course, what's needed here is your cooperation, and that we can find the values that are okay and objectively proven. And of course, we keep doing it because we want to find out how many Fontan patients we have in Germany. Many thanks, Steffi, for the introduction, and thank you also for the invitation. that enables me to come here in this group and speak to you and can introduce the Fontan-Hearts-App. I am not a medical practitioner or a professional, but I work in software development, and via an effective family, the contact was established to Steffi Sänger. And our vision and the work that Steffi is doing is very impressive, what she has built up in an honorary position and founded this organization, and also what's important, what's behind it. And we heard today a lot what kind of problems we have as affected people, as the doctors and scientists, and in order to alleviate the situation. And one possibility to alleviate it from a technical perspective is that to connect everyone in order to create a common platform for an exchange of information, of data in Germany. Of course, it has to comply with the data protection regulation, but in this context, the development is being financed by Fontan-Herzen, and we, as a development companies, are on board. We also have prepared a video that introduces the app briefly, and also is a call for donations in order to further develop the app, and in order around this idea of the platform for Fontan patients, and also to reach the community of Fontan patients and digitize them and help the people affected. Well, in this regard, you probably got a brief impression what the idea is behind it. Not just to be a data collection platform, not just to bundle knowledge, but also be an app for everyone. What does it mean? One app for everyone. We included different institutions, people who cooperate in this context. The doctors, the researchers, the scientists that deal with this topic, they are looking for solutions for a group of people who are affected by this severe heart failure, and then they get to they experience problems, and we include people affected. We include the families. They not just are exposed to the clinical problems, but also due to all of these problems that are connected to it, long hospital stays, unclear communication, and we have a community as we see it in Fontan-Herzen EV that supports each other, that in their problems, and try to find a solution to alleviate the problems in the community in order to, for example, initiate such events as this one here today in order to bring together the doctors, the professionals. That's what we have, why we have the technology. Of course, that includes us as software developers, and but also many others, medical devices, and also in the technology. We are, as an app, right in the middle in all of these areas. We are the interface, so to speak, and we want to bring everyone to a digital table in order to exchange information, data, produce results that wouldn't be possible to do it on a local level, because there are not enough Fontan patients in Germany or even worldwide. So this is a complexity that doesn't allow to do this in an analog way, to bring all these people together to one table. That also means that the functionality has to exist for everyone. It's not an app that is just for the families, for the community in Fontan-Hearts-App, but also has to include the complete range. For example, we have a questionnaire, and that's the advanced digitized version that has been used before in the research projects. This is included in the app. We will have a diary function that we have already developed that enables us, as we heard, to include the activities and track them, because activity, sports, moving is very important for Fontan patients. So how can we then detect the impacts in the everyday life? So the studies are important, and they have to be also significant statistically. And this enables us a look into the everyday life. This is important, that we include the everyday life of the patients as far as it's possible, and then with a diary export we can see the last couple of weeks and months, and in order to understand what has happened, what kind of symptoms appeared. And currently the measures are that, I write it down. I write it in my own WhatsApp group, what kind of symptoms have appeared, and things are being overlooked, and the medication that has changed is probably not noted properly. And all of this can be standardized with the app, so that the affected families have an overview, but also the doctors and the researchers, the scientists have they updated the current state. And also there should be functionalities like the Fontan Wiki that can support us with information. And we heard before that there's a certain a kind of uncertainty when it comes to the families, because they are not medical practitioners and professionals. We need persons who have dealt with the topic for a long time, so that we can publish the results of this research in the Fontan Wiki, so that a layperson can also understand it, and as an effective family or patient, you can look and have an exchange also within the chat, where the affected persons can have an exchange on certain topics, medical topics, transplant topics, very simple things as well. For example, the start of the school life. These are topics that can be discussed on the platform, and beyond that, there will also be the possibility, for example, within telehealth, to talk to experts that work voluntarily and support the Fontan families with their information, and also organize an online meeting that can help to strengthen the community with events. For example, we had a musical study and a dietary course that can be done online. And beyond that, this can also be used, for example, to present the results of studies or announce studies and ask for participation in studies. And so that we get this picture of a community, an app for all that can be used by everyone, and so that everybody can be brought together at the digital table, in addition to the symposium that only happens every 1.5 years, but that we have a constant exchange. What does it mean concretely? We mentioned it before, the questionnaire with the initial collection of data Of course, that has to be done also sequentially. We have the diary function where we look at the medication. We can look at the symptoms. We can look at sports and activities and many other medical values that become more relevant if you, as Steffi announced, agreed on a schematic overview for these topics so that we can follow the development, and then in order to have it available in a standardized form. And of course then the Fontan Wiki, where I can find answers for my questions no matter what the topic, the AI chat that then administers this collection of knowledge. If it's such a complex topic with all the different influences, it can lead to a confused situation. Therefore, we want to have a chatbot on the basis of the Fontan Wiki, can give concrete answers and administer them. The chat online meeting, telehealth, I mentioned that before. So in addition to that, we offer the possibility, due to our history, if you want, in software development, to have a certain degree of support when it comes to data analysis. We use in all our software products a graphic technology that enables us to analyze complex data structures, to model them, and also to find the deviations in order to cluster different systems and make them visible. So this graphic technology should also enable us over time to enable an ad hoc data analysis in order to test hypotheses very quickly. Because if we have an hypothesis, then we need a reference, a value, and a person that can support us. We have seen many symptoms, as Steffi said, that appeared where you had a hypothesis to it, but you didn't have the possibility to test it. So with an app that enables and provides such a graphic technology, it will be possible to do it. And what can it look like? For example, we have two people here, two persons that carry out different activities, take different medication, and show different symptoms. And now, of course, it's relevant to differentiate where the overlaps are, and then such a picture is very useful. And with this technology that we normally use in fraud detection, that we can use it in a good way to identify where the overlaps are to a certain level, so that we can now say we identified the medication, we identified the activities, and so on, so that these hypotheses to some extent can be validated. The ultimate decision will always be made by the doctor or by the research group, but we can validate the hypothesis very quickly. And in addition to this, to the diary data, we will also have the data points from the research project that are much more detailed and give more detailed questions and answers, and also enable then to create a certain person and categorize the activities where you have two different persons. They get the same medication, and therefore you have not just the same symptoms, but we want to extend the perspective, really. And yesterday in our get-together, we also heard about it, data protection. It's a very different aspect, and together with Steffi and the data protection officer in an ethics commission, we found a possibility to, when it comes to the personalization of an app, and it can be unified and merged with a research side. So all the personalized data can be included in the app, but it won't get into the external world. And therefore, we can use data that can be used in a research project. On the other hand, of course, we have to make the users and appliers don't have to use any impersonal approach, and that's exactly the thought behind it. We want an app for everyone, and these are the complexities that you have to solve in the area of technology, but you also in the context of the data protection and registration when it comes to this using the app. So what is our roadmap? Our roadmap here is 1 year on, then we show here, and we are already started in 24 in the first half of the year. The contact between Steffi and myself was established, and then shortly after we could start with the development of the app. We designed the basic setup, including the users, including the accounts. That was implemented, including the diary. In the first version, we are always open for any other ideas when it comes to evaluations, the data points that have to be included. We are at the moment implementing the wiki, and then we will follow up with the other functionalities. Around the turn of the year, there should be a first beta test phase for a selected circle and then selected group, and we will then send out a link via Steffi, and then it will enable people to participate in the beta test phase and give us feedback. Where are the tricky points in everyday life? What do I want to include in the diary? What do I want to add to the diary? It's not just about having a valid data collection. It also has to be practicable. If I have an app where I have to click 20 times to save the symptom, then it won't work. Therefore, we need the feedback from the science, from the doctors, but also from the affected families, so that we will have a picture of the everyday life that is realistic and can be used as such, and is not doesn't require a special observation. And then in 2025, in the first half of the year, there will be a start for the app for all the members, but not to a full extent, because the complete further development will take more time in 2025. And we have a lot on our implementation list regarding the different functionalities. So in the second half of the year, this will be part of the completion of the app. That's how we plan it. And then it should go into operation. And then, of course, always be further developed, because we know such a system is never really finished. It can always be further developed, and we will do it. And of course, we hope for the support of the doctors, the research institutions, the centers, also the affected families, that we get their support in order to create an app for everyone, because we can only do that if we talk to everyone. And yeah, therefore, my request to you, and I think I speak for you as well, Steffi, how can you support us and Fontan-Herzen? Well, by donations on one side, but also by helping in the development of the app, and collect donations, give information, whether it's within the diary entries or the wiki entries. I think we have a lot of plans, and I look forward to every support, and I think Steffi as well. And in this sense, thank you for your attention. And I stayed exactly on time because the lunch is waiting.
Herr Raab, vielen herzlichen Dank.
Mr. Raab, many, many thanks.
Ja, eine solche App ist,
yes, of course, such an app will never be finished, and therefore it's a good concept to do it incrementally. And the good thing about it is that the different steps then can be understood by everyone. And I think it's a good approach. And here I would like to also say that this app, this vision for this app came about because it is no longer possible to provide all the families with information, exactly the information they need. And this app is available 24/7. And whether you are in the clinic or at work, and there is a call from the school that your child isn't well, this is the possibility to have with the support of AI to get an answer. The quality, of course, depends on all of you, on your contributions. We don't want to, give you any obstacles. We want to help, but we can no longer manage it. And I can only say we get so many calls for help, and that we are exhausted. I mentioned it also. Mentioned it at a political event. We have reached the end of our powers, and we need the help so that affected families and persons can get the help they need. And I hope you will be open again towards this and adopt our thoughts and when it comes to administering medication, that the children will be able to take it at an early stage. We all have different experiences, and that they can be found out anonymously. For example, when is it best to take the medication during the day, and which have the least side effects, etc. This is very important, and a lot of families want to know more. And there is a lot of requests and need for information. And thank you for your wonderful presentations. We, of course, would like to ask all the speakers to come to the front to take a photo. And we also have a little present for you, and everybody else can go and get some food already.
liebe Mitstreiter, liebe Zuhörer, wir wollen in ein paar Minuten wieder starten. Ich empfehle einfach, Tee, Kaffee, Getränke mit auf den Platz zu nehmen und dann können wir auch starten. Vielen Dank, bis gleich.
Please take your seats, everyone. We're going to continue shortly. Thank you.
liebe Mitstreiter, liebe Mithörer.
Dear
Hoffe, dass
participants
Sie alle Ihren
everywhere
Tee und
here
Kaffee
and
Platz haben
on the
und
internet,
frisch
I
gestärkt
hope
sind
you
und
come back from
mit mir
lunch
bereit
refreshed,
sind,
maybe with
den
your
Kollegen,
coffee
der
or
von
tea.
am weitesten wegkommt,
And now I'm going to
zuzuhören. Ich
introduce
freue mich,
the
dass,
person that
Moment,
had
jetzt muss
the
ich mal meinen
longest
Zettel hier
journey
alles
here.
sortieren, dass
And I'm very
Herr
happy
Dr. Gupta in
to
Vertretung
welcome
von Herrn Dr.
Mudit
Dori
Gupta, who is replacing
uns etwas erzählt.
Dori.
Halt, ich bin eine Einheit weitergehupft. Ist
No.
mir jetzt klar geworden.
No, sorry,
Bitte
I made a
das zu
mistake.
entschuldigen. Herr Rauch.
Mr. Rauch, Professor
vielen Dank,
Rauch.
dass Sie gekommen sind und
Thank you very
uns
much for
etwas
coming
erzählen
and
können, möchten, wollen über die Unterstützung von
talking
Fontan-Patienten
about the
zur Verbesserung ihrer Lebensqualität.
support
Vielen Dank.
of Fontan patients so that they can improve their quality of life. Thank you very much, ladies and gentlemen. Here you see product concepts. I am rather exotic here. I am a biologist, I'm a chemist, I'm a pharmacologist, so I'm not a therapist in the strict sense of the word. I own a company that since '94 is providing the reference substances for natural medication, and I am in charge of the new developments of products. So you have to look at this from the legal point of view. From the legal point of view, I'm an expert for pharmaceutical products. And this is what I deal with every day on a daily basis. So that means that we have theoretically three options to intervene in the natural medications level. So you can have plant-based medications, but so there is a lot of regulation. So substances with also medications with more than 3 substances are not cannot be approved, are not approvable. So the other option is that theoretically we can ask whether we have the functional foods. Functional foods are dealt with in the food laws, food acts, and there's a special authority, the EFSA, in Parma, Italy, and it provides for the option that these products can be marketed. The restrictions here are that you will not find a functional food and foodstuff because this authority since 2007 is not including medications on a natural basis in their list of approved products. So then the only option left to us is food supplements. So the curse of natural food supplements defined by the pharmaceutical industry is that we cannot market them, so at least not in their effects on the health. So theoretically, they shouldn't have any effect, because if they had an effect, then automatically they would be medications. They would be drugs. So either they fall under the presentation drugs or under the functional drugs. So you need for the approval 6 to 8 years. So if you have a problem until you have solved it, then in most cases the problem doesn't exist anymore or has changed. So the prerequisite that we have to deal with is that we have a negative interaction with conventional medical therapies, and they have to be excluded. So this is only and exclusively about the supportive effects. how can we support the treatments without having any interferences? So we talked about the effect. So I've just said that plant-based products are possible, and there are regulations concerning that. So a product that has been approved in its country of origins for 30 years and has been without any negative effects since 15 years in the EU, then you can introduce it, you can file for approval, and that reduces the process of approval to 4 years. So if we look at the options that we have, what problems could we face in terms of Fontan interventions that we've heard a lot of in this morning? Then according to our considerations, we have 3 areas that could be of importance. The first would be protection against infections, which of course pose a problem. And then furthermore, we have heard several times about the support of the natural liver function, which is not without complications, because in this area the products many times are called detoxification. So how can you detox a detoxification organ? So that's a very strange prerequisite. But we will see that there is a different option still. I will talk about this later. And then the other interesting area is the increase of the physical and mental performance. And now we always have the question, how is this supposed to work? I've just said that I am someone who is responsible for the gold standards of phytopharmaceuticals in the European area. Insiders know that additionally, I am the German representative, or one of the German representatives in the international ISO standardization in the Asian supplemental medicine. So that includes the Chinese or Korean, etc., natural medicines and other medical systems referring to them. So the Secretariat for the products of these areas of medicine is not in Asia, but it's in the German DIN authority, which is to say on my desk, more or less. So I deal with the fate of 1.5 billion people who are using the supplementary substances additionally. So we're not against traditional medicine. We say that we need both systems to work in parallel, to complement each other. So what options do we have? How is this going to work? The Western medicine has highly effective substances. We've just heard that new substances are due to come on the market, and these are integrated into therapy concepts. But, and that's the big problem, they are also all mono-effective. So, because if you add another substance, then they will not receive the classic approval. But the organism is a complex combination of various interacting metabolic processes. So how do we deal with that? So basically, it's a multifactorial approach. And this is the approach that we need in order to have a realistic opportunity. So we need targeted, effective plant-based combinations built on global effect, experience, and knowledge-based natural substances matrices that are optimally combined. Just to give you a small example, people know Johannis herbs, which are pretty effective. But if you isolate the substance, the effective substance, then it doesn't have any effect because it doesn't have a biological effect. So you need to keep it in the substance surroundings. So we have a protection against infections, so against bacterial infections. So we have antibiotics. We have some nature-based concepts, but they are not important. Then in the viral department, we have treatment with medication. We have vaccination and prophylaxis. For example, here, Echinacea, we tried to use to stimulate the immune system. Ever since the pandemic, we have had to learn that this is highly risky. So if we have a certain type of virus, this highly stimulating and unspecific stimulation of the immune system is very risky. So now these are two names. So we have here Compalmum and the Shu Feng Shidu. So the non-specific immune system may not be activated, may only be activated, but not overly regulated. So the people the medical personnel had a very highly stimulated immune system, and if they added these substances to that, then they suffered consequences. So we have a specific immune system that should be activated and also overregulated or upregulated. So we have to look at this in detail. So this works in theory, yes, but in practice, in the case of the pandemic, for example, it didn't work because the specific immune system was regulated downwards. So the creation of antibodies, I'm not going to talk about because this is a different lecture. So in terms of the prophylaxis, this is about creation of a depot of natural active components. So you will tell me from your perspective that this is a lot of nonsense. Because the classical pharmacology says that all this does not work together. And I would say you are right. So if you have mono substances, then you have pharmacogenetics. And if you use natural substances, then you can forget this kinetics. This is something that you don't learn at university anymore if you study medicine. We have one university in Germany where we have this again, and where I actually do hold a lecture once in a while. So this is the virus itself doesn't have a metabolism, but we have to selectively work with the metabolism, and that's the big problem. If someone who already has former deficiencies, as for example Fontan patients. So Shu Feng Shidu was the only medication, one of three, that were introduced in China, obligatory, but they couldn't export it, or they wouldn't export it. So we have a modification with an activated system from the natural medicine used in influenza and in corona as a prophylaxis in order to prevent a infection. So I must say that ever since our staff is being provided with this natural medication, people are not on sick leave anymore. So this means that the Shu Feng Shidu is to be taken for 3 days, and you can purchase it in the pharmacies. It doesn't need approval. So the prophylaxis as a food supplement is approved because there's only one substance. So I talked about monoactive ingredients. So the phytocomplex is a build-up of active complex depot in the body because of the evolutionary adjustment. So if we look at the liver function, the liver decides based on the evolution, I know that. So there is a low dosage, and is there a high dosage of a monosubstance? So the liver reacts in different ways. So, but if we look at the liver and how to control it, so detox doesn't exist, as I said. So there is a plant-based combination. So if we know how to combine the substances with each other. And we have to remember one thing. Every plant contains between 1 and 2 million components. So if you compare several substances, you have very different active substances. So you can actively change the creation of the cells. So this is something that has been researched for the last 60 years, and that is something that I have taken over from someone a long time ago, and he said you have to do something with this. You have to create an actual substance. So the liver cells divide, but not as quickly as the healthy liver cells. And this means that the structure of the liver can be improved. But we have to say very clearly that the relevant thing for you is that it does not interfere with the flow dynamics. So the flow dynamics, which is created by this disease, is not altered. And now we have an increase in performance. There's the question: how can we make sure that the body can perform better? So I would like to ask someone who has used or has tried out these medications already, and maybe she can say a few words about that. So just for you to understand, we don't have enough 5-hydroxytryptophan in the metabolism, so the steps is not sufficiently in the bloodstream, and we don't have enough substances necessary for deep sleep. So now I would like to ask you to give us a few comments on this. Yes. Good afternoon. I'm Sophia. I'm an affected person. I'm a patient, and I'm 44. So I'm a 44 Fontan patient, a 44-year-old. So for 13 years, I have been looking for things to support me. So I am as well as I am today because I'm looking beyond the horizon. So whenever a doctor says to me, no, we can't do anything, I'm trying out something. 0.5 is something that I used at school when I had problems to concentrate in the last lessons. I would have loved to have this when I was at school. So I'm self-employed. I lead quite a big team. I perform very well, and I'm clearer and fitter in my head. And I always say, tell the parents that I use everything on myself before I recommend it for the children. So when I was a child, I had many infections, and since last October, I haven't been ill. And for a Fontan patient, this is wonderful not to have these diseases and infections. And I'm very grateful for these wonderful products. So we have two things. So 0.5 is also available for high-performance athletes. And we have a proposal for you. We have a new variant for children where two other components, caffeine and taurine, have been reduced massively. And we have two plants that support the heart and the circulation. That's allicin from garlic in a combination. And on the other hand, the classic Weißdorn, which protects the natural cardiovascular function. So this is a company that I have established. So they are implementing my idea, which is cosmetics that you can eat. So never put anything on your skin that you wouldn't be prepared to eat, because we need to be very careful. Thank you very much. I hope this was of your interest, and I'm looking forward to the discussion.
Vielen herzlichen Dank. Gibt es
Thank you very much.
Fragen?
Do you have any questions?
Es ist ein Ausflug in eine andere Dimension
This is
this
is a journey into a different realm. So, and that's why it was very interesting. Thank you very much.
Jetzt komme ich doch wieder zu der
And now
Anmeldung zurück,
I'm
die ich
going to go back to the announcement that I anticipated earlier. Dr. Gupta,
in Vertretung von Herrn Dori,
he is representing Mr. Dori, and he's going to talk about lymphatic interventions in the USA,
Thank you for
in
coming.
Philadelphia.
Thank you. So my name is Sumita Gupta. I'm an interventional cardiologist at the Children's Hospital of Philadelphia, where I work with Dr. Dori and Dr. Chris Smith. I'm very thankful and humbled to be invited here to speak, especially by a group of patients and their families. I'll talk briefly today about lymphatic interventions in the US and the team-based approach that we use. Because I'm from America, I have to give financial disclosures. I have none. And this is a brief outline of what we'll talk about. Vibeke had done a fantastic job of introducing the lymphatic system earlier this morning, including its functions and its anatomy. So I won't belabor all of that. So suffice it to say there are many important functions of the lymphatic system. It exists for a reason, for transporting a number of critical compounds and fluids. But I'm going to really focus on the physiology of the lymphatic system, because for us, when we think about our patients with Fontan physiology or other congenital heart disease, the physiology of the lymphatic system is what is causing their problems that brings them to the clinic with plastic bronchitis or other issues. So the organization of the lymphatic system, we think about it from an outside in or from a bottom up approach, and there's places where the fluid is produced, it's collected, and then it makes its way up and eventually enters the venous system. And issues at any point along this this track can lead to symptoms.
Diese Fälle,
so
da kann
there's a number of
zwei
factors
Symptome
that
geben,
affect how the
einige
lymphatic system
Faktoren, die
functions and
die
flows. Some of
Funktionsweise,
them are
die
summarized here, and I'll focus on the ones that are most
im
relevant to our
Lymphsystem
patients
beeinflussen
with single ventricle heart
und
disease.
besonders wenn
The organization of lymphatic flow disorders can be broken down in a number of different ways. The way that it's organized here is by compartment. So where in the body is the lymphatic fluid collecting or leaking, and therefore what symptoms do the patients present with? Is it belly swelling? Is it diarrhea? Is it coughing up casts? Or is it fluid accumulation? And each one of these symptoms and each one of these compartments have their own approach for imaging and diagnostics, but also for intervention. So starting with imaging, and as I mentioned, it's a team-based approach. So the papers and the collaborators that I'm going to mention come from all different specialties and all different areas of expertise. So this work was from David Baiko, one of our radiologists, a diagnostic radiologist, and he went through our experience with patients who've had a Fontan and looked at what their MRI, and these are conventional MRIs, so no lymphatic expertise needed, no contrast needed. These are standard MRIs that can be done at any center. Looking at what their MRIs look like before they have a Fontan surgery, and then compare that to their outcomes after the Fontan. And did they struggle or did they do very well in the hospital after their surgery? And he was able to organize their lymphatic imaging, their subtypes, as type 1 through 4, depending on how severe the lymphatic system looked. And again, this is conventional MRI. So type 1 is described here, very little in the way of edema or fluid accumulation around the neck or the chest, so a fairly normal system. Type 2 is a bit more severe. The fluid starts to accumulate in the neck area. Type 3, it enters the mediastinum in the center of the chest. And then by type 4, there's fluid accumulated everywhere into the lung fields. And these are the patients, the type 3 and type 4 especially, who tended to struggle quite a bit after their Fontan surgery. So long time in the hospital, lots of chest tube output, struggling on diuretics, sometimes readmitted for more fluid after they went home. So again, this type of subtyping is now part of our routine at the Children's Hospital in Philadelphia, but also many other centers that, again, does not require any lymphatic expertise, but before a patient goes for Fontan surgery, to be able to give the family, the patient, the surgeon, some idea of what to expect in terms of what their hospital course is going to be like. And as I'll mention at the very end, this pre-Fontan imaging is now influencing exactly what surgery the patients end up getting. As Vibeke described, at CHOP we have an XMR suite, so an MRI scanner that's attached to one of the cath labs. There are other centers that have something similar. It's not necessary for doing lymphatic interventions and imaging, but it's convenient that we don't have to transport the patient very far. And then after, in the cath lab, they get lymph node access. This is the sort of imaging that we get when we inject contrast during the MRI. And we typically do 3 compartments of access. So first is the intranodal, so into lymph nodes that are in the groin. A small needle is inserted, and then contrast is injected to get a picture like what you see here. And the same animations that Vibeke had in her slide are 100% relevant here that Dr. Dori had made, that shows that the fluid gets accumulated in the central lymphatic system, makes its way up the thoracic duct, in a normal circulation, empties into the central veins, which are usually in the left neck, but not always. But then when we have disorders of lymphatic circulation, and there could be leaks into the chest like this patient had, the intranodal imaging can be helpful for seeing those, as long as the source of that leak is somewhere from the thoracic duct, which is what the intranodal injection will show. But then there's other compartments as well that have lymphatic fluid, as well as sources of lymphatic production. So the liver is a major source. About 40% of the lymphatic fluid in normal patients is produced in the liver. And those lymphatics can be accessed directly as well with a needle near the portal vein. And so you'll get a different picture and a different set of information with this hepatic imaging. And so you can see the thoracic duct usually, but not always, but you can see abnormal channels, or in this case, very normal channels coming from the liver. But what we worry about is if there's retrograde flow, so the flow is coming out of the liver, and then instead of going up and out like it's supposed to, it's finding its way somewhere else. And so that's where symptoms like PLE can come from, and I'll show some of that imaging. And then the final compartment that we typically, in our standard patient, get access into is into the mesentery. About another 40% of the lymphatic fluid is produced in the mesentery. That's collecting fluid, that's and absorbing fats and other nutrients from the bowel. And then that gets funneled into the central system. And so we can look on ultrasound for lymph nodes or other channels in the mesentery and then access those. And so then you get a different image and a different set of information about what this third compartment is doing. And I'm trying to paint a picture that there are multiple compartments that are sometimes related, but sometimes independent of one another, and getting multiple sets of information from multiple points of access can paint a cohesive picture about what's going on for a patient. And as we know with all of our patients, every patient is individual and everybody has their own combination of things that are normal or things that are not. And then besides the MR lymphangiography, we can also do direct access of the lymphatic system. So this is a needle being placed into the thoracic duct. The way that's done is through access in the abdomen. Sometimes it can be done from elsewhere. But with a needle and then a wire in the thoracic duct, we can get a picture of what the central system looks like. So the cisterna chyli, where the lymphatic collecting ducts all come together in the abdomen, and then the thoracic duct, which goes up and out to the veins. And then, as I mentioned, there can be obstructions or issues all along the way. And so now the thoracic duct outlet, that's the last part of the lymphatic system, right where the duct is supposed to enter into the venous system. There can be issues there. And so we can use ultrasound to image that area, and we can inject contrast into the lymphatic system and then see how it's draining or emptying into the vein or not. And we have plenty of patients who have a normal connection here, but we have lots of patients who have an abnormal connection here. And so that gives us one more point of information about what's the thoracic duct outlet look like. And so all of the imaging I've described so far, direct access to the duct, the ultrasound of the thoracic duct outlet, 3 points of MRI access, that's our standard approach for every patient, regardless of what their presenting symptom is. And which is why these tend to be all-day procedures, because this is what we do 8 a.m. until noon, is get each one of these bits of information to then plan what our afternoon will look like and where we actually need to intervene. So that's where the imaging goes, but now let's actually talk about the interventions and what do we do. So this slide and then the next one are a whole list of the different sorts of procedures that we do. I'll leave it up for a moment. And then the next one has an algorithm of the way that we think about our sort of workflow for different patients. But as mentioned, we try to organize things by compartment. So pulmonary lymphatic perfusion is in the chest. There's abdominal lymphatic perfusion in the belly. There's also a cardiac or vascular reasons for lymphatic issues, and then there's surgical approach to our interventions. And this is that algorithm, which has already been published back in 2022, so it's available in the literature as well. But again, going by a compartment approach, that dictates sort of based on each yes-no point or branch point of what does the physiology look like, what does the anatomy look like, and what does the patient have, and what are their symptoms, dictate what is the best way to treat them. So starting with the pulmonary lymphatic perfusion, or the chest compartment, plastic bronchitis, chylothorax, two of the major issues that we see, both in our Fontan patients, but also some non-Fontan patients. And you've seen plenty of images of what plastic bronchitis casts look like. Chylothorax is an accumulation of lymphatic fluid in the chest around the lungs. And this is the same animation where you see fluid, instead of just exclusively going out to the vein, you'll see these green dots coming out into the lung space as well. And this is an example of what an intranodal MRI looks like for this patient with severe chylothorax and pulmonary perfusion, where instead of just one single line of flow through the thoracic duct entering the vein, it's now entering the chest in a number of areas, up into the neck, into the mediastinum, kind of all over the place. So our approach initially, back when these procedures were first dreamed up and started, was usually to just embolize the entire thoracic duct. It is by no means an easy thing to do, but it's relatively minimally invasive if it's done with needles and catheters, and by eliminating or occluding the entire thoracic duct, any possible channel that's perfusing the lung will be embolized. The downside of that is there's knock-on effects. All that lymphatic fluid is still being produced by the liver, still being produced by the mesentery, but now it has no outlet. And so you can see knock-on effects of that. So now our approach is much more targeted. We try to be selective of what we embolize, so specifically getting into the channels that are perfusing the lung. So this is a pre and post image of a patient who had a selective embolization done for perfusion of the chest. And the idea at the end of all of these procedures is to leave an intact thoracic duct, preserve that normal central system so that there is always a normal outlet for the lymphatic fluid that's constantly being produced. So it's a schematic of what selective embolization looks like. These are what our outcomes are as of this moment for plast bronchitis. Jill Savla, one of our cardiologists in the group, went back through 63 of our patients who came for plast bronchitis intervention. Most of these were selective embolization. All the patients had reduction in their amount of casting in a median of 19 months of follow-up, with 80% of them not having any more casting at all. But of course, with more time, we'll get more follow-up. But these are what those outcomes look like. And comparing that to the graph on the left is freedom from transplant or death with plast bronchitis before the area of intervention, and then now this is our freedom from intervention or transplant in the era of intervention. So plast bronchitis tends to have pretty good results. But now getting into a new compartment and adding another layer of complexity, as we've done more of this imaging, especially imaging of the liver, we have realized that many, many patients, at this point it's probably the majority of patients who have abnormal perfusion in their lungs, have what are called hepatopulmonary connections. So these are connections, lymphatic vessels, that the body is forming that go straight from the liver, usually the liver capsule, into the lungs, the mediastinum. These bypass the thoracic duct. They are not coming from the thoracic duct, and if one did intranodal imaging, so just looking with injections into the groin, you would not see these channels because they're not coming from or ending in the thoracic duct. So the only way to access these and image these is by accessing the liver with needles, and then we can embolize them once we can see them. So this was a very dramatic example of a patient who had this entire network of lung perfusion supplied by a single hepatopulmonary channel. We saw it on the left by MRI, and then now on the right after we've injected an embolization agent into it. The outcomes from our hepatopulmonary experience are described here. So we went through our patients who've had any sort of imaging with us, and of the 100 or 50 so who had symptoms that related to their chest, we identified hepatopulmonary connections in 44 of them. And of those, if we were able to actually image them and access them, we could embolize them. And these are what the follow-up outcomes are. Very short-term follow-up relative to some of our other patients, but still tend to be fairly durable results, but not always. There are certainly patients who come for repeat interventions because these are very pesky channels to find, let alone to engage and embolize, because they don't show up on a lot of our imaging unless you have a needle in just the right spot. So another reason why we try to preserve the thoracic duct as much as possible, because as much as you can keep the normal lymphatic system intact, then it stops the body from wanting to make new connections and new ways of getting this lymphatic fluid out, because the liver is producing fluid constantly, liters and liters every day. So we want to keep a normal outlet for it. Now moving on to the abdominal perfusion. So two major categories that we'll talk about in terms of symptoms. Protein-losing enteropathy, you've heard a number of times today, is a real scourge for patients, incredibly uncomfortable, incredibly debilitating. By itself is often an indication for transplant listing at a lot of centers. And then chylosociety, so an accumulation of fluid in the abdomen. These often go hand in hand. As you lose albumin and you lose your protein in your body from PLE, you can start to build ascites as well. So there's a number of abnormal channels that can form, but the ones that I'll highlight are hepatoduodenal connections, so hepato coming from the liver and then draining into the duodenum. That is not the normal direction for lymphatic fluid to go, but in these patients, they're dumping fluid out into their abdomen, and that's where they're losing all their protein. So this is a schematic and an image from an endoscope during one of the procedures with blue dye being injected, just like Vibeke showed earlier. And here's a dramatic example of what that MRI will look like, or MR lymphangiogram. So this is contrast that's being injected into the liver. immediately dumping and flowing into the duodenum, into the bowel, and then actually getting reflux back to the stomach. So that's protein that's being lost is diarrhea. That's protein that's being lost that leads to swelling, abdominal discomfort, and all of the issues that we see for these patients. So the approach to this also, we try to be more and more selective, even though it takes more time and is more laborsome, to not only eliminate these hepatoduodenal channels, that means accessing the liver and then glue embolizing the channels going to the bowel, but also accessing the bowel itself to eliminate these what are called periduodenal channels that are wrapping around the bowel wall. And now that we know where the duodenum is on the patient and there's an endoscope in place, we can then inject dye followed by embolization agent. We're using a combination of glue as well as an agent called STS, which is a sclerosing agent that we learned from our interventional radiology colleagues as something to use for lymphatic channels. And again, this is an image you saw earlier on Vibeka's presentation, but this is what we're looking for on endoscopy to tell us we're in the right place. We have a needle in a spot that's actually draining directly into the bowel, and then we'll follow that with an embolization agent. Things to try to sort of visualize these periduodenal channels. So there's injecting into the liver to see the channels. There's using the endoscopy, and then there's also we can fill the lumen of the bowel with water or saline so that it makes these lymphatic channels and the leaks from the lymph much more visible to us. So here are our current outcomes for PLE interventions. So this is from a paper a little bit earlier this year looking at albumin levels, following them out for the duration of our follow-up. And generally, our patients tend to do quite well by 24 months plus post-intervention. More than half of them still have an albumin level above 3 grams per deciliter, which for us is sort of a good or a positive indication. But there are caveats to this, and when we look at the actual subtypes of patients and populations, just doing the hepatoduodenal channel, so just liver access, is only helping some of the patients. But when we actually go and do the more laborsome work of doing the individual channels that are perfusing the bowel directly, the periduodenal channels, we get better long-term outcomes. And the same thing applies for maintaining the thoracic duct. By keeping the thoracic duct open, we get better long-term outcomes than if we embolize it. Moving up the chain to the thoracic duct outlet, that can also be obstructed, and so if there's stenosis of the outlet, we can use our interventional cardiology tools of wires and balloons to balloon open that occlusion, reduce the pressure gradient, and make it easier for the lymphatic fluid to flow out. Same thing if there's stenosis or narrowing of the thoracic duct itself. And then finally, if there's total atresia, so complete blockage of the thoracic duct, we can then turn to our surgical colleagues, and we have two very talented surgeons who work with us, Katz Meda and Pablo Laje, to do surgical lymphovenous anastomoses. So here we have a thoracic duct catheter and a catheter in the azygous vein to map out where they can do a surgical connection like this to keep maintaining a way for the lymphatics to drain out into the venous system like it's supposed to, because the body will keep making the fluid regardless if we do an intervention or not. And then finally, what I'm going to talk about is multi-compartment lymphatic failure. So these are patients, we see this very commonly in Fontan patients who have all the compartments affected. They have chest symptoms with effusions or plast bronchitis, and they have abdominal symptoms. And Dr. Haraska, a surgeon in Milwaukee, Wisconsin, had described this procedure of surgically connecting the innominate vein, which is where usually the thoracic duct drains into, down to the heart, to the atrium, to get a lower pressure for the duct to drain to. And this is what Vibeka had alluded to in her slides. There's also a procedure described by Christian Kreutzer's group of doing this at the same time as the Fontan. So when I talked about that MRI imaging we use to risk stratify our patients before they even have the Fontan surgery, our patients who are type 4, so the most severe, or a type 3 who've had lymphatic issues in the past, we're often recommending that at the time of their Fontan, they have this modification be done. So they have an innominate vein turn down done surgically at the same time as the Fontan procedure to try to decompress their lymphatic system as much as possible to avoid those longer term issues. And these are Christian's data of that. Our center's just been doing the first 2 or 3, so we don't have a lot of our own institutional data yet, but Dr. Kreutzer's data is listed here. But what we have been doing, and this is pioneered by Jack Rome and Chris Smith in our group, is a transcatheter or a percutaneous version of the thoracic duct decompression. So using covered stents to replicate a new pathway for the lymphatic fluid to get from the innominate vein down into the lower pressure atrium of the heart. And these are data, this is an example of how that procedure is done. So a simultaneous injection of all the various structures, so we know exactly where to direct the needle when we're puncturing from the neck to avoid skewering something that we don't want to hit. Once we have a connection, using a balloon, then a covered stent pathway to make a new path for the lymphatic fluid. And these are our data so far. So we have follow-up of 33, actually it's 34 as of last week patients. 20 of them we have follow-up out since through 2023. All of them multi-compartment patients who had this procedure done. And over time, it's not a universal fix. About half of the patients responded. Some were non-responders. Some responded after some modification. Either the pathway needed to be ballooned or restented, or there was clot that was forming that had to be removed. But there were some patients certainly who benefited from this being done. But then we tried to stratify who are the ones that tend to respond and benefit. And we know that the hemodynamics matter. So a high pressure in your atrium and a high pressure in your Fontan together does not spell a high chance of success with this procedure. But when we have a big transpulmonary gradient between the Fontan and the atrial pressure, so low atrial pressure, high Fontan pressure, those patients tend to do better. So we try to use this to risk stratify going into a procedure like this. So finally, to summarize, Fontan failure is a multifactorial process, but it's intimately related to lymphatic failure, and that we try everything we can to maintain ductal patency, keep a working thoracic duct, and based on the compartments that are affected in each patient, we choose a treatment pathway that will be most likely to help them, and then for the most severe multi-compartment symptoms and multi-compartment pathway, thoracic duct decompression is more and more becoming an option. But even in centers without lymphatic expertise, the baseline imaging before the Fontan procedures even done can help patients, families, and the care team know what to expect and make modifications as needed. So I'd like to acknowledge an enormous group of people in the Jill and Mark Fishman Center for Lymphatic Disorders. Yoav is my mentor and spearheaded this whole field that we're talking about today, and I can't thank him and the rest of the group enough. I mentioned Chris Smith and Jack Rome by name, but there's too many people to count to thank. So thank you for your attention.
Dr. Gupta, thank you very much indeed for this extremely systematic approach. And, well, thank you very much.
Of course.
I would gibt es da akute Fragen?
Are there any pressing questions right now? Because otherwise, I would suggest
discuss this approach after the next two presentations, so we can do that together. Is that okay?
Sounds great. Yep. Mm-hmm. Thank you.
Ja, jetzt
okay.
Ich Herrn
now
Bauer
I would like to ask
kommt
Dr.
aus
Bauer.
Linz, habe ich das richtig gelesen? Ja.
He's from
Lymphatic
Linz,
interventions and Fontan circulation.
and he's going to talk about lymph interventions and Fontan consultation in Linz. Thank you very much. It is an honor for me to speak in this very important event and conference. I'm going to talk about lymph interventions and Fontan consultation in Linz and the lymphatic programs that we have established together with the center in Philadelphia in order to reflect a little bit what's happening there in Europe. Just a few words about the Children's Heart Center in Linz, which is not very well known. We are one of several heart centers in Europe. It was established by Professor Tulzer and Dr. Meyer. We've 30 years ago, and we've operated 450 Fontan patients. The management, the single ventricle management starts in a prenatal phase with interventions with the goal of to guarantee large ventricles in order to not even start with the Fontan circulation. Another focus is the lymphatic program, and we also have the Fontan Consultation and the lymphatic program that we established a few years ago. We've heard about how to care for the Fontan patients. It's teamwork. We've heard that. We have there are so many things involved in taking care of Fontan patients that one single person couldn't possibly do that. And I'm working with my colleague, Mr. Schöberts. So how do we structure our aftercare? So we have guidelines, the AHA guidelines, and then we have the guidelines from New Zealand, very good papers that for all the centers that don't have an aftercare program yet. So after the Fontan operation, we see the patients every 3 months in the first year, and afterwards every year. The half year, the 6 months controls will be done by the local doctors. We look at the bone structure, metabolism, then we have exercises, and all the radiological interventions. We have a multidisciplinary care concept. We have pediatric cardiologists and endocrinologists, radiologists and osteologists. We hold conferences with them. The osteologists and the gastroenterologists are always involved when we have problems with these different organs. Since the beginning of this year, we have a new structure for our outpatients service. So the patients come in on Thursdays for our consultation. We have 146 patients, and we apply this multidisciplinary concept to them. And we have the adult cardiology. We have a counseling. We also have a program for people 18 plus. We counsel the patients in certain areas, because this is what caught my attention when I talked to them. Some patients don't know about how their body works, and it is very good for their health that they know. So we take half an hour to explain it to them, and we discuss certain day-to-day chores, such as exercise, complications, career choice, lifestyle, and pregnancies in the older ones. So the goal is to have a structured care for from diagnosis up until adulthood. The second focus that's very close to my heart is the lymphatic program. So we have lymphatic imaging. So these are the interventions that we can only do in a team. This is our team in the pediatric cardiovascular center. So radiologists, cardiologists, and the surgeons, and we have specialized nurses because they need a special set of experience. We started in 2015 with the installment of the lymphatic imaging, and since 2018 we've been doing lymphatic interventions. As my predecessors already said, and the important thing when I work with the lymphatic system is that I know and understand every patient. Every patient is different. Every lymphatic system is different. We need a specialized prepare. We need a good diagnostics and then a specific therapy. In our institute, we have the non-contrast imaging, but we also have the lymphangographies, which are based on contrast medium. We need to know exactly about the lymphatic system before we decide for the surgery, because every component has an effect on the whole system. So I can. This is why in our institute we have both types of imaging. We have a function of the lymph nodes in the area of the hip, and we can do that by via injections. We have an imaging here, so maybe we can shortly run it. So we've seen certain images. We here have a case of plastic bronchitis, and on the left-hand side, on the right-hand side, we have a PLE, where we can see the contrast agent. And a further step would be this kind of imaging, and here we have a special needle that is entering in the lymphatic system close to the liver, and there you have a transfer of the patients to the MRI. So this is a logistical challenge, because we don't have the same system as we have in Philadelphia. We have to change between different buildings, and most of the interventions we carry out are successful. Another important step in the diagnostics is the decision whether the intervention can be successful or not. So we have here an ultrasound, and here you see the ductus thoracicus. And here I would like to present certain patients of ours that we have treated in our centers, and in order to tell you about our experiences with these methods. So here we have a case of plastic bronchitis. This patient had a plastic bronchitis since 2 years old, and here we have the ductus thoracicus and a 24G needle with a punctuation. And we've seen this in the video of the previous speaker. And here on the left video, you can see the catheter in the distal ductus thoracicus, and we also have a fistle that goes towards the left part of the lungs. So we had a mixture of labiotol and closed this fistula. This patient, after this intervention, didn't have any symptoms anymore, no plastic bronchitis, and this was 4 years ago, and he's symptom-free now. So this is our experience, that the patients with plastic bronchitis react very well, and also on a long-term basis to this method. Another form of therapy that my previous speaker didn't mention is the unselective labiodol injection. This is a patient that has an unselective labiodol injection via the lymph nodes. So you have a punctuation of the lymph node, and here you have a normal contrast medium. And here we have a closure, an unspecific closure of the lymphatic vessels. The experience of patients with PLE are different. So we have recurring symptoms, and we haven't heard yet about certain therapy approaches in PLE patients in terms of the lymphatic interventions. But I would like to present one patient of ours with the pure intervention. So we have the connections between the liver and the lymphatic vessels are being conducted towards the intestines. So we have a punctuation of the liver lymphatic vessels, and we closed them, and afterwards the patient normalized after about a week. So this patient came in 2018, and this single intervention made him symptom-free. So the PLE-treated patients with the hepathetic approach do have a recurrence of the symptoms. So this is a different progress. So this patient was treated or came to us for 6 years ago from Romania. He is now living in Linz. He had a severe PLE with 3.5 milligram per centiliter, and he had PLE symptoms. So at first we had an MRI, and we had a proximal portion of the ductus sacricus. And I have to say that every patient is different. So this is not normal. This is not a standard case, because most patients have fistulas in the liver lymphatic system. So this patient was also published. So he's a specific case. So we tried to selectively punctuate this fistula, and we were not able to enter into the fistula. And we made several punctuations, and 2 weeks afterwards, the patient was symptom-free. So we were very happy about it for him. And it stayed like that 1.5 years, and after 1.5 years, the symptoms recurred. And here we see very clearly that we have here a connection starting in the liver. So we have another fistule, this time in the liver. And this is something that happens a lot in PLE systems, patients, that we have these connections. In this patient, together with our colleagues from Philadelphia, we tried a lymphatic intervention. So the goal is to have several to isolate the production site, let's say, and several of these patients could not be treated via the conventional method. So after 12 years, the we had the patient was symptom-free. We were hoping that this would be medium term, but the PLE returned. I'm really sorry to say that it didn't work, so we intervened again. And I think this is a basic component also for PLE patients. The decompression has the opportunity to change the physiology of the lymphatic system in order because we change the location, and the patients after this intervention with the decompression of the ductus thoraicus profits from that. So this patient has been symptom-free for half a year. So they, in this case, the connection is still open. So the decompression, as my previous speaker said, can be carried out as an intervention or as a surgery. So I would like to present another patient where we carried out the decompression of the ductus thoraicus in a surgery. And this patient was a patient with the multi-compartment problem. And after a week, they were symptom-free. But this patient has been symptom-free for 4 years now. In summary, I would like to say that the interventions in the lymphatic system are very complex. We have to know the system, we have to understand the physiology, but there's a big potential in these interventions to help certain patients in the plastic bronchitis. We have a long-term improvement in the PLE. There are certain patients that are symptom-free for some time, but the quality of life can be improved, and we can use this for patients that are waiting for a transplant or where a transplant cannot be carried out anymore. It is also very important to point out that this is a team effort and that there's a certain risk involved with these interventions. So we need the cooperation of the different experts in their fields, which have the appropriate experience, as we did with our colleagues in Philadelphia. And I would like to thank them for their cooperation, because without them, we wouldn't have been able to carry out these interventions. So this is my last slide. So we need a strong team for our patients in order to be able to help them long term. Thank you.
Dr. Bauer, vielen herzlichen Dank.
Dr. Bauer, thank you very much, especially for these very interesting and positive and negative results in case of the patients. And I think that it makes me think. No, it wasn't a question. It was just a statement. The cases were very interesting indeed. That's what I wanted to say. Thank you very much. And I said that we were going to try to have the discussion afterwards. So now I would like to call on Dr. Georgiev, also in cooperation with Dr. Dori in the US. Yes, thank you very much for this very nice introduction. I'm very happy to be here and to present our experience in Munich. We are still new in this, and we hope that we will be able to help our patients in the German center.
Now, well, we're still at the beginning, a few words about Fontan and the German Heart Center in Munich. We have a long-standing experience with this type of surgery. These are the 4 main modifications in the Fontan surgery that once it started in 1971. All patients were found with these 4 modifications in our heart center, and mostly it's the extra cardiac variant is being used today. We have more than 600 patients now, always TPC with extra cardiac conduit, mostly without windows. I think it's in most centers the case. And globally, the patients get windows as a routine. But it's important for me to say that we carry out a lot of research on the Fontan cycle. And I would like to also show Mr. Masamichi Ono. He is the chair of our clinical study team in the pediatric surgery in our clinic. And his main research area is Fontan cycle. So this is one of the most important papers and of Professor Ono. And you can see here, this has been, well, 8 years ago, and it still shows that there are almost 500 patients, that they had a very good follow-up and good long-term results. And his conclusion at the end of the paper, he says and summarizes that nowadays contemporary TCP can be performed with a low risk and provides an excellent survival in the long term. And that's correct. We know it as well. And nevertheless, it does not mean that these patients have no problems at all. And unfortunately, we know that too. And this is where he mentions at the time, he mentions PLE and liver dysfunctions. It's something that we have to know. And it's very important to make our patients feel better. And all of these experiences we can find in the everyday life with the patients, and it was shown before. And I was given this by Jörg Dori. And the normal situation is, well, you can see here the liver that is, but ultimately it's coming from the whole body, of course, and normally the drainage would be such that all lymphatic vessels are part of the central system and via the ductus thoraticus end in the vena annominima. And if the pressure, for example, after a Glenn surgery, everything is stopped here, and the image of the motorway is very interesting that was shown today. And I think it's the same here. And the Fontan patients, they don't only have a increased pressure in the upper vein, but also in the lower hollow vein. So that doesn't just lead to this backlogs, but also they increased lymphatic production. And that means that these lymphatic complications are pre-programmed, at least in one part of our Fontan patients. And this is from a very nice paper by Maxim Itkin about Fontan. It is about right heart insufficiency, but principally is valid for Fontan as a whole. And ultimately, it's about the increased production, the lymphatic production, and difficult drainage. So increased pressure, and on top of it, there is an increased amount of lymphatic fluid, and so the preload and the postload are increased. And in cardiology, we say that the patient suffers from lymphatic insufficiency, it always exists, but it's better compensated with the patients that feel well. So these things weren't really understood 20 years ago. Today we know all of this, and we also know this is the normal system, and if these preconditions are given, if you have a Fontan cycle, then you have a backlog of the lymphatic system. So then we have these compartments, and then you can have these leaks, and they present a relief of this liquid in either the thorax or the hylothorax, the breathing ducts, ascites, Proteus loss syndrome. We mentioned it before. These are the typical complications with Fontan patients, and if there's a combination, we talk about the so-called multi-compartment syndrome. And now we come back to my heart center. This is my Professor Ewert, who was present in many conferences, and he always wanted to start such a thing. Lastly, in Linz, at a meeting together with the colleagues of Mr. Dori, he talked and came back about 3 years ago, it was, and then he said, don't you want to fly to Philadelphia in order to learn it? And I did, and 1 year later, I was part of this team, and I must say it was extremely impressive what was being done, the systematic approach and development, and now it's being applied, and also how to further develop in this area. These people were shown before, Mr. Professor Dori, Chris Smith, his deputy, so to speak, and they work in the Center for the Lymphatic Disorders. This is a study from many areas where colleagues from different areas work together for the patients. Professor Dori, he doesn't just train people on site. This is what he's done, and also was very good for me. He gave me a lot of experience, but he also supports other centers, and I can proudly say it's also happening with us now. We have regular video conferences with him. We talk, about patients. And in May this year, he also came to visit us. You can see here in front, that's me, and we treat our first patient together. And I will also show some patient examples later on. But how does it work? A lot of these things we have seen by now. And then ultimately, this investigation starts at the heart catheter, and then the lymph system is cannulated, the lymph nodes, the liver and catheterium, and then the MRI is being done, and the so-called T2 are being used, and also lymphangiography with gadolinium is being done. So then you know where the problem is, and then the patient gets to the lab, and that's being done in the catheter lab. And so the patient has a long way ahead if he's being treated like that. Logistically, it's quite difficult. It was mentioned before. You have a so-called hybrid suit. You see the catheter lab, and there's the MRI, and they are next to each other, and there's a door in between that makes things easier. And here you can see the MRI table that's being docked on to the other table, and the patient is being moved to the other bit so that everything stays in place. And if you see how it works, and it's like the F1 when they change the tires, and every one of these people knows exactly what to do. And you can see also how much teamwork and logistics is behind it before you get to this perfection. Unfortunately, we don't really have the possibility. It's not in our building, it's 3 floors below, but we have our own, we have developed our own modification, and we built the access in a pre-room to the MRI. Here's the door to the MRI, and this is the room for the preparatory work. And we use the T-arch. It's a mobile X-ray installation that's available in a lot of hospitals. And here again is the MRI table. The child is on the table, and by means of ultrasonic rays and with this C-arch, then the table can move directly to the MRI. We didn't use it at the beginning, and the needles always slipped, and it was a big improvement. We are doing it as a standard now, and you can see many people are standing around, the nurses, the anesthetist, and anesthetist. And yeah, this is an example of a diagnostic procedure that we have done. We do it ourselves. It was very difficult. In the last couple of cases, we have to repeat the measures, and in the meantime, it always works. And so we puncture the lymph nodes, and also it's being done in Linz. And this is the last patient that we had. He is 9 years old, and he has protein loss. It's similar to your patient, Christoph, where you said via the liver you couldn't see it, but via the lymph nodes it was possible. And therefore I'm showing the picture of the lymph nodes. It was embolized once, and for 2-3 years it worked well, and now he shows another protein loss in 6 months. And we could again see this accumulation in the duodenum, and now is the plan to discuss the treatment with Professor Dori, and then also treat it at the next visit commonly. And this is our experience with Professor Dori of this year. What regarding the treatment, we have a protein loss patient, and it worked really well. The child really improved afterwards. And we also have 2 patients, treated 2 patients with chylothorax, also successfully. And so it's asymptomatic at the moment. The 3rd patient is a small girl that also had chylothorax, and they constantly suffering. We could treat the effusions. There's no longer any effusions, and now she has ascites. and we plan a further diagnosis. And it's very important, if you look at the lymph system, if you have more leaks and one leak is closed, then it goes potentially stronger via the other ones. And this is what you have to understand at the beginning, that the symptoms of one problem can be transferred to another. For example, as it was the case with this child, and interestingly, the child did have no ascites before, and it wasn't relevant at the time. And but with the blockage of the thoracal compartment, it was it led to another leak. And we hope that we can help the child. You can see here in this child the anatomy with the contrast MRI that we did via the lymph nodes. And here you can see it is a normal ductus thoraticus. The child also has two upper hollow veins. It's quite complicated anatomy. This is the normal ductus thoraticus, is quite intact. And then on the left-hand side, you can see the vessels that cause this massive phylothorax. Here you can see it also in the liver diagnosis. These are the pathological vessels, and these are hepatopulmonal connections that we have mentioned already. And here with this child, we have Professor Dori cannulated the ductus thoraticus via the abdomen, and here you have a so-called microcatheter, and then you can do this angiography almost like a normal angiography, and only in the ductus thoraticus. And here the normal ductus thoracic duct can be seen. Maybe better in this picture, you can see the microcatheter here, and these vessels here, they cause this massive chylothorax of this child. And you can see what's going up here slowly is the normal ductus thoracic duct that ends in the vein. So what did we do with this child? We used the glue in these pathological vessels, and so we injected this glue and made sure that it doesn't reach the vessel system that can reach to enormous complications. And here you see this hepatopulmonal connections, and they were closed. And with the child, we no longer had any effusions. We have helped the child, but lately he was returned as an outpatient, and we plan the next treatment together with Dr. Dori. You can see here that you can only see the thoracic duct, and there's nothing going into the lungs or where it doesn't belong. And then I want to show you at the end another patient, and then I say something about the decompression. It was been shown before. It's a really great idea to reduce the pressure against the thoracic duct by here's the anonymous vein, and that is normally connected here, where the pressure is as high as in the Fontan cycle, between 10 and 18, so clearly higher than we have as in a normal person. And then here you can connect this vein surgically. Victor Draska did it for the first time and published it. And then you can lower the pressure in this vein to the same level that is in the heart, and that's usually 5 to 7, 8 millimeters lower. And that leads to an improvement of the symptoms, especially when it comes to the multi-compartmental syndrome. And you can do it also with the Rome procedure that Chris Smith published, where he published the results 2 years ago. And we have such a child with a multi-compartmental syndrome. The child was in a really poor condition, multi-compartment syndrome, a big belly and massive nursitis. and we try to show the lymphatic system, the lymph system, and due to the enormous belly, I couldn't really use a needle, and the child was ultimately well, going towards the palliative solution, and then we had as a last alternative to reduce the symptoms to try this decompression, and they agreed. And it seems this is the initial anatomy here. Via the left neck arteria is being injected, and with this catheter you exit the Fontan tunnel, and this catheter is in the left part, and here you can see that you have a long procedure in the atrial, and you can see the blood is flowing via a detour in the atrial, and the child, well, for about 1.5 months, didn't really improve. 1 week was better than worse again, and now in March of this year, I found out or heard that everything has improved, and he has a permanent drainage. Of course, he goes to school with support, but it's clearly better than this critical situation that he was in before. And we will talk about a transplant again, and but there are possibilities to treat these things in a therapeutic way nowadays, and I hope that these options will increase. And ultimately, I want to say something that was also said by previous speakers before, and I think it's extremely important in this area. I talked about this center before, and these are the doctors that are involved in the center. Now we also have Dr. Gupta with us, and these are only the doctors that are doing it directly. And behind this lymphatic center, there are a lot of other people. I just took it from the website, but it's really the case that there are colleagues from a lot of various disciplines that are cooperating and are doing it for our patients. And I'm very proud at the end that with the support of this team, that we could start such a process. Thank you very much.
Herr Georgi, vielen herzlichen Dank.
Thank you very much.
Die Summe dieser 3 Vorträge ist ja
the sum
sehr
of these
beeindruckend.
3
wenn ich dran denke,
speeches is
wie
very
die Berichte
impressive.
über diesen Ansatz vor 4, 5 Jahren bei mir angekommen waren,
When I heard about it
wie weit
first
sich das
3 to
jetzt
4 years ago,
differenziert
I'm
hat
very impressed by how much it
abbildbar ist
has
und
been
reproduzierbar ist,
differentiated
finde ich das
and
eine
how much
extrem
it is
beeindruckende
reproducible. So that is a very
Entwicklung.
impressive
Gibt es
development
dazu
indeed. So do you have
Ihrerseits Fragen,
any
Hinweise?
questions, comments?
Ich gestehe, dass wir
I admit
zeitlich
that
extrem
we
im
are a
Verzug
little
sind.
pressed for
Und insofern
time.
gesehen wäre
Extremely,
meine
actually.
Tendenz, weil
So
die
my tendency would
Aussage
be,
ist ja
since the
die
statement
Motivation
is the
und
motivation
die Weiterentwicklung
and the
dieses
further development of
Arbeitsfeldes
this area
unter
of expertise
der, sagen wir mal so, Leadership der
under the
Gruppe
leadership of the
Herrn
group
Kollegen Dori
around
ist
Professor
ja relativ
Gorley.
eindeutig. Und insofern gesehen
Dori,
wäre meine
sorry,
Tendenz jetzt zu
is
sagen, einfach
pretty
weiterzumachen. Sind Sie damit
clear.
einverstanden?
So
Wenn ich jetzt keine
I think we should
Widersprüche
just
höre, mache ich das
continue.
einfach.
So if you don't,
Vielen Dank.
if you
Vielen
agree,
Dank.
then we could just
Vielen Dank.
continue. Thank you very much.
Ich würde jetzt Dr. Benjamin, danke. Dr. Benjamin Kelly
Now I would
aufrufen
like to
zur,
ask Dr.
Punkt
Kelly
Changes von
to
Zahnpatienten,
talk about
proteomische Veränderungen bei
proteomic
Fontan-Patienten.
changes
Vielen Dank.
in
Thank you.
adults.
Yes, I'm sorry. Unfortunately, my German is not good enough to do this all in German. But I know the translators are doing an excellent job, so please take the headphones on if you need. First of all, thank you, Frau Singer, for arranging this day It is amazing what you do, and it must take an impressive amount of work to arrange a day like this. So I'm very happy to see that you have help. And I'm sure that there are a lot, both here and at home, that appreciate your dedication. It's very inspiring. So my name is Benjamin Kelly. I'm from Copenhagen in Denmark, and I'll be giving this short talk about the proteomic changes in adults with a Fontan circulation. It will not so much be about how to treat these conditions. It will more be about how to understand what it means to have a Fontan circulation. What are all the things that might come down the line? So Professor Ubinger explained this very beautifully this morning, that being born with half a heart or having a Fontan circulation is about much more than just the heart or the valves or the rhythm. It can also be about the blood vessels, the lymphatic vessels. We heard how they can leak out places where they're not supposed to leak. It can be about the intestines, the metabolism that was also presented this morning that may or may not be changed, and there's still a lot to be known or researched in this area. And then the liver, Fontan-associated liver disease is definitely something that is there, and that as people with a Fontan grow older, we'll probably see more of. And I could continue this list. There's a lot of things that we're starting to see, and there's a lot of things that we don't know much about. So that was the background for this study, where we wanted to kind of take a step back. We wanted to see if there were any methods that would allow us to look at a more whole body perspective of individuals with a Fontan. And luckily for us, these three methods actually somehow allow us to do that, and they've all become more available, they've become cheaper, and people have become better at doing them. So the genomics, that's kind of the whole recipe book. That's all the recipes that are us. The transcriptomics is kind of the small RNA sequences in every cell. That is each individual little recipe for the proteins that are created throughout our body. And then finally, proteomics, that's all the different proteins that are up and down regulated in our body all the time to make it function. And that's the approach we chose for this study, where we applied these big proteomic panels to kind of quantify the protein levels in individuals with a Fontan circulation compared to controls who had a normal biventricular circulation. And our aim was to kind of provide this comprehensive proteomic description of the impact of living with a Fontan circulation. So it was an exploratory study. There were no, we just wanted to come up with ideas, try to understand better. We didn't have any big main hypothesis or specific hypothesis we wanted to test beforehand. We used these large protein panels. We included 58 adults with a Fontan circulation and 29 matched controls. We tried to have them equally spread between those with the right dominant ventricle and those with the left dominant ventricle. And to do that, we took only the tricuspid atresia patients and the double-inlet left ventricle patients from Denmark. We took peripheral venous blood, prepared it to plasma, or plasma as you see here, and then we ran these O-Link Explore panels that gave us the levels of all these proteins. Moving to the results. After quality control, we ended up with the relative levels of 2,605 proteins. And after imposing more strict criteria for statistical significance, we found that 89 of the proteins were significantly lower in the Fontan population, and 424 were increased in the Fontan population. It can also be illustrated like this, where the proteins to the right, or the red ones, are the ones that are increased. The more out to the right you are, the bigger the difference, and the more up, the more significant the difference. And similarly to the left with the blue proteins, those are the ones that are reduced. I don't normally work with proteomics, so we brought an expert along with us, and by his words, this is the most significant difference he's seen something have on the human proteome. So living with a Fontan definitely changes the proteomic signature in the body or in peripheral venous blood. So this is basically the easy part. Now we have the levels of a lot of proteins, but then the big question is, what does it mean? What do they relate to, all these proteins? And that's when you go towards this biological pathway analysis, where you look up these big databases online where all proteins are registered, and the function of each protein is plotted in, and that allows you to make plots like this. So these biological functions in the body were the ones that had most proteins affected in the Fontan population, and these were the ones that were increased. So you can see blood vessel development, vasculature development, angiogenesis. Quite a few of them were overlapping, and we kind of put them together into overall categories where the main things that were, or the main proteins that were upregulated in the Fontan population compared to the controls were related to the development of new blood vessels, angiogenesis. This was the strongest signal. I think 20% of all the proteins that were increased in the Fontan population related to the development of new blood vessels. Secondly, a lot of proteins related to the levels of calcium in the body, calcium homeostasis, and bone development and ossification. Even though these were adults, there was also quite a few of the proteins that were increased in level that related to the development of the heart and the organs, the heart morphogenesis. And then finally, proteins related to inflammation and kidney function, inflammation and the liver, and fibrosis, and also kidney function and fluid balance in the body were also increased. Decreased proteins related primarily to muscle cell structure and function, and then the production of cholesterol in the body, but also some mixed signals regarding the metabolism in the body, and I'll get back to some of those points. Just to bring forward the things we found most interesting from this study and what we think deserves more attention, more research. This very, very strong signal towards increased blood vessel development. We think that's really exciting, and we couldn't help but speculate what's driving this signal towards blood vessel development. Is it hypoxia, as we heard about this morning? Is it different flow? Is it mechanotransduction? Is it inflammation? We've no way of saying that. We can just say that a lot of these proteins involved in angiogenesis were quite significantly increased. VEGF-A, VEGF-B are the two main endothelial growth factors that cause angiogenesis. And this angiopoietin 2 is also involved in the destabilization of blood vessels before they sprout out and develop new small vessels. And from the literature, there are also studies in the single ventricle population that describe that if you have higher levels of this angiopoietin 2, then your outcome will be worse during the subsequent follow-up period. We also looked at the corresponding receptors, and please bear in mind that this was not receptors on the surface of the cell or on the endothelial cells. These were soluble receptors in the plasma. So we're still a bit uncertain how to interpret these levels, but, VEGFR1 was increased, whereas VEGFR2 was decreased in the Fontan population. Just a little side step. We've heard quite a bit about the lymphatic system now and how it can leak out because we find all these abnormal lymphatic vessels that find their way out into low pressure compartments and start leaking. So we're very sure that factors causing development of lymphatic vessels would be increased in this population. So a little bit disappointed when we found no difference at all in these central growth factors for lymphatic vessel development. So perhaps the development of these extra lymphatic vessels happened years before, perhaps during the fetal stages of life or during the period where they undergo all these congenital heart surgeries. Relating to the liver and Fontan-associated liver disease. Found an increase in TGF-beta, which is the central inflammatory protein involved in fibrosis. Also found increased levels of IL-6, a cytokine involved in inflammation, amongst other cytokines as well, just underlining that probably many of these individuals live with kind of low-grade inflammation throughout life. And finally, the end product of fibrosis is increased levels of these collagen fibers 1A1 and 3A1, and both of those were also increased in the Fontan population, indicating fibrosis somewhere, perhaps in the liver, perhaps in the kidneys, in the heart, or somewhere else. Muscle and bone. Overall, proteins relating to the structure and function of muscles were decreased in the Fontan population compared to the controls. Probably relate to lower muscle mass, but there's also been studies indicating that perhaps some of this is predisposed, where they have predisposed to a different body composition with less muscle mass, more fat, perhaps to save oxygen, perhaps to make the whole organism more efficient. And a similar point is to be made about these two proteins, which are found on the two types of muscle fibers that are predominantly found in the muscles, where there is an oxidative type, slow twitch oxidative type muscle, which uses relatively more oxygen, and a fast twitch glycolytic type, which uses less oxygen, relating to the talk this morning. And we found that the oxidative type, the type of muscles that used more oxygen, was relatively decreased compared to the other type. So perhaps that's also some kind of adaptation pointing towards less oxygen consumption, more effective organism. PTH, parathyroid hormone, was increased. Perhaps an explanation for the osteopenia found in this population, the decreased bone density. And FGF23 is a protein that's involved in the regulation of phosphate, but also vitamin D. And it decreases the production or the hydroxylation of vitamin D, and also increases the degradation of vitamin D, which also aligns with the reports of decreased levels of vitamin D in this population. Metabolism. These two hormones, leptin, adiponectin, are satiety hormones. They give you a feeling of being full and don't give you the urge to eat more. They are typically related to the amount of fat tissue in the body. And those were upregulated in the Fontan. Again, perhaps that's because of this altered body composition. Perhaps there are other reasons. Cholesterol. The building blocks for different types of cholesterol were decreased, especially for high-density lipoprotein. And relating to the energy production, we also were quite interested in finding things that could indicate if there was more glycolysis, because that's less oxygen dependent, more glycolysis because that's less oxygen dependent, and less beta oxidation of fatty acids. But here the signals were quite mixed, so definitely also an area for more research. There's a lot of limitations when you do a study like this. Even though the protein levels may be increased, we don't know why they're increased, and we don't know what the consequences are for each individual. These proteins were measured in the plasma of the arm, and perhaps if we measured them anywhere else, in the liver, on the arterial side, these levels would have been different, or the picture would have been different. And then again, we took out small samples from the Danish Fontan population and some matched controls. So depending on how these groups were put together, the risk of bias between these two groups. For the conclusion, or I would probably rather say all the questions that are still there, there definitely seems to be a very strong signal towards blood vessel development in these individuals, and it aligns with all these extra blood vessel collaterals that may arise It may be also spilling over into the lymphatic system, fibrosis in the liver, other places, inflammation, fibrosis. There's also a signal towards that. And then, again, these alterations in muscle and bone signaling biological pathways that may have consequences for these individuals, and perhaps somewhere along these, there's a target for treatment so we can help them with the end consequences. And a big question again, what are the drivers for these changes? Is it the hypoxia? Changes occurring to create a more oxygen-efficient metabolism or organism? Is it inflammation? Is it differences in flow? All these things, we don't know. There are a lot of potential explanations, and I think we'll have to come up with new studies to kind of narrow this in. As I said, yes. So with that, I'd like to just thank you for your attention, and happy to take any questions you have.
Dr. Kelly, thank you very much indeed. Are there any comments or questions? Ich nehme es als ein völlig neuer Aspekt wahr, wie Hämodynamik und Proteomics eventuell
I take it that this is a completely new aspect.
Do you have
and
any idea at all how there could be a connection between those sides of the story? Okay, okay.
It's a very good question. As far as we are now, there are multiple, if we take angiogenesis, for example, there are multiple explanations. And probably there's not one correct answer. Probably it's all working together.
Okay.
So inflammation will be some part of the explanation.
So we should meet here again in 5 and in 10 years and then start to discuss this again.
Hopefully, yeah.
Okay, thank you very much indeed.
You're welcome.
The most fascinating thing about this event is that there are so many different aspects that come into play, science in future and the persons affected and all kinds of persons affected. So therefore I am very happy that there is a parents' report, and therefore I call Mrs. Romanowski and look forward to welcome the team. Hello, I'm Thora, and over there you find Leo Fontano. Do you want to say anything else? No, okay. Well, I've never done it before. I will make a lot of effort. I'm Jenny, I'm the mother of Life and 5, who is healthy, has a healthy heart, and Tore is 9, who has a hypoplastic left heart syndrome. Also the initiator and organizer of the Heartspeed Ultra donation. Tore was born with HHS in 2015. In 2020, due to severe complications, he had to undergo a lymphatic intervention, and his general state was very critical. And after the lymphatic intervention, he went through an absolute horror phase. He was always afraid and shouted because he was experienced severe pain. He was no longer the happy and lively child that we knew before, but he was caught in his old world. He was apathic. He was no longer able to speak in a proper way, and he had to relearn to walk, not because he didn't know any longer, but because he was panically afraid of the pain once he started moving. And because he hardly had any muscles left. His small body at the age of 5 only weighed about 10 kilos. We also had to start to feed him again, and we are still having difficulties to find the right nutrition. It took 9 months to bring back the boy that we knew, and in everyday life the worries are permanent, especially for the small brother life, and most of his classmates he only reaches up to the chest. And other children, once he knows he needs help, they pick him up as a small child, which really worries him because his head is just as healthy as a normal child. So the Fontan complications and the bronchial coughing are a lot of problems, create a lot of problems for us and his brother. And we often have the feeling there is not enough time in order to help children with Fontan complications. And therefore, we need urgently a clinic-independent interdisciplinary Fontan Competence Center in Germany, where specialists as endocrinologists and pulmonologists, etc., can look after Fontan patients. Such a center could help families such as us in order to get targeted help and expertise, medical expertise. And this is where we need Fontan-Herzen, and the organization creates a platform that enables a knowledge bundling and exchange of information. Without the continuous work of the organization, the build-up of the symposium, and an exchange of valuable information, we would not have the access to the knowledge that is required for our children. And sometimes I didn't know how to continue, and that's when the trail running in nature over many hours kept me alive. It gave me the calm needed and the courage, and that's when I started Heartbeat Ultra. It's a run or a walk where everyone can participate and can find out about the situation of our Fontan children and what it's like to overcome your limits every day. This is what we have to do every day. We have to face these difficult tasks that we have managed at the end, and overcome these limits, and that's what makes this event very special. And I would like to ask all the doctors and supporters that are fighting for the future of our children, the children with half a heart, and especially ask and thank the support of the runners and walkers in Heartbeat Ultra. It helps us, their donations help us to find urgent help. And thanks to everyone, also to Fontan-Herzen, for their engagement, for their support. And I would like to mention that we still have some free places. You don't have to go to Falda to the run. You can do it virtually. And I would like to really thank you for the support. Last year, we had received 50,000 donations from the runners. Thank you very much. Well, I think that was a very nice introduction to the break, and I think we should have received some more food, and you can all strengthen yourself For the next round, we are somewhat delayed, and therefore we would like to inform you on time, and you can bring your coffee back to your seats. And I think Jenny reached many hearts in the room, and we hope that there are many, even if it's only virtually, that can participate in the run and help Tore and all the other children. Well, dear colleagues, dear co-fighters, dear guests, bring your tea, bring your lemonade, bring your coffee to your table, back to your seats, and then we can reconvene our meeting and start with Mr. Tim in a minute.
Wir möchten alle bitte wieder auf ihre Plätze bitten.
So we'd like to ask you to come back to your seats, all of you.
Mit an Tisch nehmen,
bring your drinks with you and to the table, and then we can go into the final straight.
Unser Professor
And our professor, Mr. Tim from Hamburg, is already here, ready to start. Okay, I believe I can introduce Mr. Tim, Professor Tim. He is looking at the questions that we have from a different perspective, well, meaning whether the building of centers is improving the quality of hospitals. This is a discussion that's taking place on various levels at the moment. I don't want to get started or start any political discussions, but I'm looking forward to his views. Dear Steffi, Mr. Professor Gabert, ladies and gents, thank you for the invitation here to Magdeburg. You can hear from my dialect, I come from Hamburg at the University of Fresenius, and I would like to talk about better quality through center formation of hospitals, and therefore I would like to get started with some numbers where we can all praise ourselves, and if we don't see it in an international context. If you look at the data that I brought with me, we can praise ourselves because the life expectancy in Germany increased by 1.3 years from 2007 to 2020. We can also praise ourselves because of the stroke mortality went down from 8.1 to 6.2 per 100 shots. And also the heart attack mortality went down from 100 shots from 10.2 to 8.3. So these successes can be celebrated, and think that we moved ahead of other countries, meaning we are at the forefront in Germany, but that's no longer the case. And these frightening pictures that we will see in a minute, we put them into context. The colleague of Denmark reported as well. And the heart attack mortality over the age of 65, I didn't really have any compatible data to put it in a context in Germany. But if you look at the comparison, you can see in Denmark a life expectancy that, again, is praiseworthy. And we can see an increase of 3.5 years. I'm not coming from Hamburg. I come from Schleswig-Holstein, which is even closer to Denmark. But it's not due to the weather. It's because the Danes understood to restructure their hospital landscape and service provision. And they did it in a radical way that is lacking for me in Germany somewhat. And if you look at the center formation, they managed also to reduce the stroke mortality from 9.3 to 4.8. So they went ahead of Germany. The same goes for heart attack mortality, where there is a figure that shows a reduction from 8.5 to 4.5 per 100. And then you look at the comparison. If you know, you have an improved picture in Denmark, and we always talk about this in Germany. Whereas the clinical density, when I hear from people where they are going on holiday and they go to different airports, not in Hamburg or in Hanover instead, but when they have surgery ahead, and you know, either the knee or heart surgery or whatever, then I ask myself, okay, it's easy to go to the airport. That's not a problem. But to receive a hip operation or a knee surgery, it has to be close to the residential place. But what about the emergency case where the patient has no choice? And for 25 years, I've been in emergency centers and in ER, and so these patients are usually brought to stroke units, and that also have a certification. But we have a better provision in Denmark, for example. So the cups have to be removed, and there is some the situation in Denmark, at least when it comes to the data. The sun is shining, but we have to look at the density of clinics also in Germany, and you can see that there are gaps. And if you would establish clean centers, then the provision can be even better. And in North Rhine-Westphalia, they have a new plan that has led to a lot of cleanups, and also with a lot of opposition in the press, etc. But if you look at the numbers now, and compared to Denmark, we find a better quality, an improved quality. So what have the Danes done? They changed and cleaned up their hospital structure. They have established 22 centers of clinics, and when it comes to an extreme surgery, you don't have to go to the university hospital for 3 days. There are other providers, and that is foreseen in a legal transformation, and there will be a vote on it on the 22nd of December, but some politicians don't really know how dramatic the situation is in Germany. And anyway, you can see the Danes have cleaned up their hospital structure in a relatively short period. Of course, they needed money for it. There were so-called hospital super funds to enable this, and we talk about hospitals of 900 or 800, 900 beds. What does this law mean? What does it provide for? One topic you can delete immediately, which is retention financing. 60% are planned to be financed via retention, but I would see it as a part of financing. So the performance groups, that's also one part where the hospitals with a lower quality in future will no be part of the provision. I would also not go into an airplane that hasn't been maintained and has just received the permission to start. And so this is where it's going. And of course, we have to have structural and personnel requirements must be met in future in order to retain or maintain a performance group. That also means that a hospital, by means of concentration and center formation, can then make use of an entire team, but it only goes via this networking of clinics. And what's important here, the service group, internal medicine requires the service group for internal care medicine. And here they try via cooperation agreements to establish a vehicle to maintain their status. So what do I want to say? Only well-structured clinics with center characteristics with high case numbers will receive or retain their care mandate. And for those who are working in the hospitals, In North Rhine-Westphalia, for example, they have been hearing also of the planning authority, and the necessary allocations were made. Of course, we are coming up to Christmas, and so it's also that there was a lot of opposition against patients going for 30, 40, or 50 kilometers to the next hospital. And so if you look at this, the planning sheet says in that when it comes to heart surgery and children and young people, you can see that the conclusion of the GBA via directive about measures for the quality assurance of radiation of cardiac surgery. I think there are some impulses that have to be introduced, and they are still lacking. And I think that this audience here can certainly give an impulse in this direction, and you know, not just you know, just contact the mediation committee, but give some impulses. And in this planning sheet, they point out the GBA directive, and that's a minimum requirement in order to account for performances and services. And a lot of insurers for hospitals always point out this future provision order, and so due to well, if there are any faults and defects, of course, it's the question of responsibility that has to be looked at in future. I'm always looking at the time because I thought there would also be some questions, and therefore I want to use the 3 minutes for a discussion. So the conclusion, I didn't want to give you a lot of slides, but maybe our follow-up government will focus on very different topics and not go back to the hospital reform. There are also things that are also very critical. If small hospitals are closing, you have to offer an alternative to the people, and it's not a nice perspective to shut the hospitals. There are solutions that I mentioned due to the level 1 clinics. And so the conclusion, the formation of centers, one colleague said a multi-professional team, we need endocrinologists. Another one said if it's only possible in a complete team, it was a big team that was required. And I think this is, this statement points to that as well. We will get a better treatment and life expectancy if we can work in highly complex and high-quality teams. And here as well, when it comes to hip and knee surgery, I wouldn't go to a clinic that does it 50 to 60 times a year, but I think per surgeon 200 is the required number, and where I know I'm well treated. So a small conclusion, maybe it's only for one center, or maybe it can be a European center as well. That is left to the professionals here in the room, but I think the complementary offering has to be there, and that's right. And I think also the psychiatric aspects of the parents and relatives are required, as you said, with your son. And I think when you are affected, then you know that the aid is required, support is required when it comes to the psychosomatics, and then we can also talk about it, and whether it has to be in centers and how many. But as long as it's centralized, I think then especially when it comes to the parents to children with Fontan heart, they can then have a contact center, and as long as the surgery can be avoided, and experiments. And then we have 90 seconds, I think, if my clock is, my watch is right.
Herr Tim, vielen herzlichen Dank.
Mr. Tim, many thanks.
Jetzt würde ich ja gerne eine ganz
I would like to ask a provocative question. How many inhabitants are there in Denmark? About 6 million. That means we have 16 times Denmark in Germany, roughly. Is that not one of the central problems that we have? Because the hospital planning is not a federal problem, it's a regional problem. Yes, well, if you want to remain a prime minister in a state and a region, then you cannot do it as a mayor of a small town. But if you look at the numbers, the Danes, due to their countrywide structure, they were able to do it quite radically. And I think they have dared to do it, because otherwise they would have had some real problems. And yes, questions, Heiner. Mr. Tim, I have to say that you threw out the baby with the bathwater. I'm the father of this GBR paper, and it was a process between 2003 and 2009. It also led to a lot of criticism. We wanted to do a centralization. We talked about 4 centers at the time. I would favor a centralization. In pediatric cardiology, we have a centralization. The small centers that used to do surgery in the past no longer do it. And that has stopped it thanks to the GBR directive. And so a lot of people were happy about the GBR paper, but today it's very difficult to implement it. I think everywhere in the countries these provisions are violated. And I also have a question, because we mentioned a lot the interdisciplinary approach and service, and heart center, and the illnesses are not always cannot always be treated interdisciplinary. So it's a problem as well, because after completion, a lot of organs, a lot of vessels, the overall problems have to be considered. And therefore, in the first step, we would be for an independent clinic that would also be a superordinate model, but it could then be a virtual model, right? Well, it would be difficult to say which clinic can do it, but therefore we say that it has to be clinic independent. We are looking for ways to get started on a way, and then you have a chance to find solutions, because we don't know what this way will look like, but we have to get started on the way for our children. And we also have a greeting of Mr. Lauterbach online, when he commented on our approach. If we only had a few centers for our Fontan patient, we would have centralized knowledge, and it would have a big effect on the studies, and we would have a lot more experience that could be used in a bundled way for the families. And then if these few centers would cooperate, then it would be an enormous chance for our children. Yeah, many thanks. Many thanks so far, and I think this will keep us busy for the next 10 or 20 years, this further structural development, and I'm curious to see where we will end up. And now I have to look, Mr. Dr. Illing von Duisburg, together, well, with the presentation of the treatment of obstruction in Fontan cycle on different levels.
Ja,
Sie müssen jetzt eigentlich schon
herzlichen Dank.
Thank you.
I had to continue my presentation in English today. I'm very thankful for being invited today to speak about our experience for management of patients with obstructions today. I can see the pointer. Actually, it's over there. I will focus on Fontan obstructions in my presentation. Do we know how many patients are living today with Fontan obstructions? The exact number is unknown. Can someone help? Oh, yeah. I have, yes. Okay, yeah. I have no disclosures. The Fontan procedure is considered the final stage for palliation for patients with single ventricles. The ultimate goal is to separate both circulations and providing the adequate oxygenation of tissues and organs in the body. So the first one, modifications was introduced in 1971 by Fontan and Baudet, and is almost abandoned and replaced over the years with other modifications as more efficient, energy-efficient way to support the pulmonary circulations. The lateral tunnel and the extracardiac conduit. On this diagram, I would like to highlight the risky areas for obstruction development in the Fontan pathway. First of all, the suture line. The suture line of anastomosis may provide a post-strain effect and provide a narrowing of anastomotic area. So artificial materials that we use very frequently have no growth potential that lead to discrepancy between the tunnel, lateral tunnel, or extracardiac conduit and native structures. By the way, the artificial materials are predisposed to pillow formation, kinking formation, and folding that provide obstruction as well. And in particular, the left pulmonary artery is always a major concern by Fontan patients. On this slide, I would like to highlight the main types of Fontan obstructions that we faced. The first one is obstruction in the lateral tunnel. The artificial material produced the folding here. So the next one is the extracardiac tunnel that crosses the midline of the body to the right side. And this extracardiac tunnel is extremely long and is predisposed for the development of obstructions. So on this picture, you can see the obstruction has developed at the connection with pulmonary artery. The next one, here is kinking between the IVC route and the extracardiac conduit. Extracardiac conduit is from artificial material. And the last one is also Fontan-Pathway is obstructed, but with a combination of, with obstruction or stenosis of the left pulmonary arteries. So 114 selected patients were involved in this study, and the vast majority have received the extracardiac conduit. On this diagram, you may see the 18 millimeter conduit is prevails over the others. Long-term follow-up. 19 patients has developed obstruction in the Fontan pathway that made up 16.6% of incidence. On this Kaplan-Meier estimate curve, you may see the freedom from the development of obstruction in the tunnel, in the Fontan tunnel. The median time span was 19.7 years till this event has occurred. Let me mention briefly the main disadvantages of using artificial materials or grafts. No growth potential, no intimal peel on luminal surface or endothelialism, possible kinking and deformation of the artificial grafts and thrombosis. Such important drawbacks lead to reinterventions. So it's amazing to note that size of the lumen of artificial grafts is going to decrease. One study from Petal and the group from Los Angeles Children's Hospital has showed that 1/3 of patients has developed significantly 25% decrease on the lumen surface as early as 6 months of palliation. Another study from co-authors from South Korea have investigated changes in PTFE grafts and concluded that in average cross-sectional area is going to be decreasing in average by 14% in 3 years after Fontan palliation. So how it could be visualized? By CT scan or MRI scan, you may see the extracardiac conduit here. And the peel formation is visualized. The thickness of this wall on the CT scan or on this MRI scan is about 3.5 millimeters. And of note, there is these extracardiac conduits have no more circular shape, but elliptic shape. One more MRI scan example. Here is obstruction in the middle of the lateral tunnel, probably caused by during the folding formation in the lateral tunnel. And one more time, we perform angiocardiography routinely for patients to visualize the IVC route, extracardiac conduit, and pulmonary artery connection. As I mentioned above, this extracardiac conduit crosses the midline of the body to the right because of the malposition of the heart and systemic venous return. It's always a major concern for surgeons how to place a conduit in the chest of the body, and the surgeons attempt to implant the largest size of the conduit that patient can accommodate. I have to put it very briefly, the common patient characteristic. We were able to follow the patient in a median of 11.3 years. The median age was 14.7 years. Mostly the patients had complaints for fatigue or exercise intolerance, and 4 patients have symptoms of Fontan failure. The cross-sectional area, expected cross-sectional area, we have calculated, it was 113 square millimeters. And the IVC Fontan-Pathway ratio was 1.2. This is almost twice as much of the Fontan-Pathway itself. The 6 patients have combined stenosis over the pulmonary arteries that were intervened as well. So one more example of the 58 years old patient with atriopulmonary anastomosis. It's very rare in nowadays. And we may see that there is a severe stenosis at the connection with the pulmonary artery. And by the way, this patient had a stenosis in the area of bidirectional gland anastomosis. They both were intervened, and the patient benefited from balloon angioplasty. She has improved the symptoms, increased exercise capacity, and doing now physical exercises on a fatigue as earlier. One more example of patient with Fontan-Pathway stenosis. This connection with pulmonary artery was severe stenotic, and of note there was long-distance stenosis of the left pulmonary artery. We have to say that left pulmonary artery lies crosses anteriorly of the aorta ascendens and lies superiorly of the left main bronchus, and maybe this left pulmonary may be compressed with a dilated neo-aortic root after Norwood procedure. That is why this patient has treated with stenting of the extracardiac conduit, stent in stent position, and additionally left pulmonary artery was intervened and stented as well. Types of interventions: 19 patients were treated with different procedures, and 9 just underwent stent implantation. 4 patients have received their surgery, and 3 patients treated with balloon angioplasty. 3 of them still waiting for further interventions. So concomitant procedures were as follows. This, you can see in the slide. I would like to highlight the relief of pulmonary artery stenosis that patient has developed and required the interventions on that. I would like to show the one more Kaplan-Meier curve that shows the freedom from pulmonary artery stenosis before and after Fontan palliation. 58 patients, more than half, required different interventions on the pulmonary arteries from very beginning to the Fontan palliation. And the median age before this intervention has occurred were 14.5 years. And I'll move to the results after interventions. 6 patients have improved their symptoms as well as exercise capacity. 4 patients subjectively have improved their symptoms, but still had diminished exercise performance or tolerance. 6 of them did not respond to any interventions. Concerning the individuals with the Fontan failure symptoms, there were 4. 2 patients unfortunately died in a follow-up 3 months and 70 months subsequently. 1 patient, we have lost touch with him. And 1 still alive and actually recovered after reintervention and transhepatic lymphatic embolization. Let me move to the summaries. Fontan-Pathway as well as pulmonary arteries should be regularly re-evaluated in cath lab as well as with the MRI screening. The pulmonary vascular bed is a main concern after Fontan, before and after Fontan procedures, and should be aggressively treated before the Fontan palliation. Extracardiac conduits, Proteomic grafts, could be successfully dilated and stented in the narrowing area, and surgical approach is considered and preferred in cases of implantation when implantation of larger grafts required, or in case of combined stenosis of pulmonary arteries. As when by long segment or extremely narrowing of the Fontan palliation, the surgical approach is also preferred. Of course, for Fontan conversion as well. Herzlichen Dank für Ihre Aufmerksamkeit und thank you very much for your attention.
Dr. Elin, thank you very much indeed. A wide range of results, I realize that. Are there any questions? Yes, please.
Hi,
Hi,
fantastic talk. For the smaller patients who are getting a smaller conduit placed, 14, 16 millimeters, has anyone in your group looked at the so-called extracardiac lateral tunnel Fontan that uses a pedicled pericardium? So it's essentially supposed to be
to construct it.
Yeah, you construct the Fontan instead of PFT. It is pericardium, but it's still pedicled onto the patient, so it grows. Our center in Philly doesn't do it, but Leon Bailey at Loma Linda sort of pioneered it, and then Mark Galanowitz in Ohio still does it. And we've done reviews of some of his patients, and they've had excellent growth of their Fontan, and they, so that instead of putting in something very small that can't grow, it might be a nice alternative.
Thank you for your question, Dr. Gupta. I have to say that these 14 millimeter grafts, the patient received in early ages. And actually we learn our lessons and we don't use it anymore. The 14 millimeter grafts is very, very small thing to provide or to serve the pulmonary circulation in adults. That is why we don't use it, and we did not consider to use a pericardial grafts or something like that. So.
Thank you very much. Any other comments so far? So, thank you very much indeed.
Thank you.
Now I would like to announce a team, meaning Mrs. Dr. Aurinen Wernicke. It's about neglected aspect, but in my opinion, it can extremely influence the life quality, meaning dental care. And yes, first of all, many thanks to you, Steffi, that we can be here today. It's a great honor for us to present our project. The project is called Zahnherzen, tooth hearts, and it developed a while ago, and yeah. This is the structure, and we will explain it. I am Katharina Wernicke. I'm a dentist with my practice, with my surgery in Oldenburg, and I'm a mother of the two 6-year-old twins, and my daughter was born with a congenital heart disease, which was only diagnosed after the birth, and that really threw me back in my planning and changed a lot of things. And after this entire process, once you have started to live with it, then I noticed myself that topic of oral health is a very small point that hardly ever gets mentioned, and they have to tackle it also in social media. We noticed that a lot of questions of parents and people affected people were noticed, and also that the children in part were not really treated correctly. And then I started a call, and then Steffi posted it, and this call was directed at colleagues to get involved in this project. And that's how we got to know each other. And Kerstin then approached me, and then we started all of this 1.5 years ago, thereabouts, and Kerstin will now report what it's all about. Thank you, Steffi, also from my side. Actually, I saw Katharina's call on Instagram, thanks to Fontan-Herzen. And as I said, I'm Kerstin Auren. I'm specialist, a children's dentist, and for more than 6 years, I treated children with chronic diseases, chronic tooth diseases, and therefore I could also see how important prevention is. And then I started the project dental clean pearls, and in order to reach the children. And that's the problem, really, because the main problem with children is caries. And you will probably think, yes, it's a small hole in the tooth, but actually for us and also for the children and the parents, it's much more than that. Because the problem is very we find it very often. Every 7th child has caries, and it means that due to the fact that the children are not very cooperative and then have to get treated, the 6-year-old, every 2nd child has already experienced caries, and so they are much better served and with dentists and dental care, but it's still quite a lot, and therefore caries also is the most prevalent chronic disease in children. And with children with heart disease, it's even worse. We could show in our studies that the mouth hygiene is worse and that there's more caries, and the children also require much higher service and care compared to the healthy children. That has many causes, and they are, unavoidable, really. If you look at it, the children with heart diseases, they get much more often sugar-contained, high calorific nutrition in order to avoid loss of weight. And that's quite understandable. So they have very, very different problems than brushing the teeth, and they have a lot of hospital stays, meaning also that a lot of medication is taken with sweet juices and sugar-containing liquids, and so a lot of problems that we can see from that. And you can see it at the bottom at the one patient, that the mouth hygiene is also very strongly affected due to this growth. And you can also see in studies that children with heart diseases have more structural problems, structural anomalies of the teeth, and that can also lead to a higher rate of caries. And you look at the consequences. Unfortunately, it's no longer a hole in the tooth, but thanks to the structure of milk tooth, the they are much more, well, they can much easier lead to an infection of the nerves, and that often leads to a situation that we have here. These are chronic diseases, and where you can imagine that it can lead to an extreme invasion of microorganisms into the tissue. The children will feel pain, and they lack of appetite, and they also get soft foods, and that leads to more caries, and it's an upward, it's a downward spiral, and so with children and heart diseases, this problem of invasion of microorganisms in the tissue can lead to bacteria getting into the blood circulation, and this is what we want to avoid, and therefore for us the solution is the primary prevention, meaning toothbrushing, and of course I want to quote, optimized oral hygiene or good oral health probably protects the heart better against an endocarditis than antibiotic prophylaxis. This is from Katja Reinecker in Freiburg, a cardiologist in pediatric cardiologist in Freiburg. So we then formed and we started to be active on the level of the parents. We start to have and include the professional staff and inform them how important the topic is and how important the prevention is as well. And we want to motivate the children, and also the small pearls that you see at the top, the tooth with the baguette. This is to motivate the children to properly brush the teeth, and then they can collect these little pearls, and it's a project that you find in clinics on the wards, and that's where we want to reach the people via poster campaigns, via giving out free utensils, and to remind them every time. And also we inform the ward staff by giving presentations for the staff, and we have an interdisciplinary approach. We have pediatricians, we have pedagogues in the team, we have a lot of dentists in the team as well, and it's also a male colleague, and other than that it's all women. But we want to have improve the interdisciplinary approach, and for everyone who's dealing with the topic of children with a heart disease. And we want to network ourselves, and this is what Katharina has charted in the network Fontan-Herzen. We want to build up, we want to form a network that the parents can use once it's up and running. And we would really be glad if a lot of wards, hospital wards, would participate in our program, so that we can reach a lot of parents and a lot of children. If you want any more information, please contact us. The oral health of the children is the topic that's close to our heart, and I would like to thank you for your attention.
Sehr geehrte Frau Aurin, sehr geehrte Frau Wernicke, vielen, vielen herzlichen Dank.
Thank you very much
die ganz wesentlichen
for these very essential
den
tips
Alltag medizinisch und
that
im
are very
Bereich
important
der
for our day-to-day life.
mitbestimmen.
Yes, I have one question, because we receive many calls for help when there is a dentist intervention, schedules with a narcosis, and it is not so easy with Fontan patients. So could you say that in your clinic, for example, it is possible to have a dentist intervention with an anesthesia. So you understand that the parents need an information where can our children have a safe intervention on their teeth, because usually we don't find a clinic that says, okay, we do the anesthesia and the dentist comes in. Yes, we do have that problem. So I have a practice, so I used to work in a clinic, so I know both sides. We can do a normal intervention in the dentist practice, but we cannot do an anesthesia. And there are very few university clinics that have the free time and that have the space for accepting outpatients, let's say, and then you have a long waiting time, like a year, for example. People cannot wait that long. That's obvious. So I see that problem in my practice. So the things have to change. So that may be an appeal to the stream. So if there are some families watching over the internet and they know somebody who knows somebody, or somebody here knows something, then please use this opportunity and talk to us, even if we have been here for many hours already. Thank you. Yes, now I would like to ask Professor Höfer. He is from Aachen, from the city of Aachen, and he's going to talk about Fontan Conversion. Yes, good evening. Yes, good evening. So thank you very much for this a wonderful event. It's a great location. I'm really very impressed, and I thank you for the invitation. So I'm going to talk about the Fontan conversion. So you know this is the Fontan circulation. So this is what we wish for without stenosis. So then we have the extracardial conduit and ECC, and the Fontan circulation first of all was described by Professor Fontan, but the conversion that was invented then has its tricks. This is we had a direct contact to the lungs. Then we had a lateral tunnel later on, and then the extracardial conduit, the ECC. The colleagues from Australia that have this wonderful registry with data from over 20 years have described this. So these are the three variants. We've talked about this. You know this. So extracardial conduit has advantages. So the three variants, what are their outcomes? So on the left-hand side, you have the survival rate, and then also the freedom of arrhythmia. So the extracardial conduit has always the best results. So you have 100% of survival. And the original variant by Fontan has the lowest rate of survival and also the most problems with arrhythmia. So here we see the survival, so the causes of death. And we have the Fontan Conversion, 20% death rate or mortality rate. But the reasons are manifold. And one of the main reasons of risk factors is also the freedom of death or transplant is the arrhythmia. So the more arrhythmia as we have, the higher is the probability of not surviving the intervention. So we have a high rate of occurrence in adults. So here you have the comparison. So we have the last bar is the Fontan bar. So the have a probability of 10% that you are successful with this ablation. So it's not really successful. So at one point, you have the risk of failing Fontan. We've already talked about this several times. And this is a patient with failing Fontan from the city of Erlangen. This is very typical. So you have ascites, protein losing, enteropathy. We have several other symptoms. So now what? So you have arrhythmia. You have all these problems. This is from Asia. Heart center store does not have the solution. And then we have the conversion. And this doesn't mean like Cat Stevens that converted to Islam and changed his name. And Dr. Fontan did not convert. It's not that kind of conversion. It's a different kind of conversion. This is the first publication of the conversion of Hiller and Lux from California, Los Angeles. And here you see this was the first antechamber, 6 millimeter large. And this was the result that then we had a lateral tunnel in 1994. And this group in the US that used this technique more than anybody else were Rodinus and Baca and Deal. These three from Chicago. And the methods of these this Fontan conversion are here. So we have a resect of a large right atrium. We have an atrial septectomy. We have a biatrial maze. Then the extracardiac conduit, Glenn, if it hadn't been there, and then the epicardial pacemaker, so a pacemaker. And about the ablation, I would like to say something. So you have to distinguish between a left heart syndrome or a right heart syndrome. So typical for the prepusal atrophy is with this tunnel that you use these lines. And if you're on the left-hand side, you have the pulmonary veins. And these are pre-described lines. And depending on where you are, you have to change these lines a little bit. So here you have the classical tunnel. Here you have the artery and the arteriseptic. These are the pulmonary veins. And here you have these lines and the double outlets and the AV channel. And so the last publication of this group, I think, is from 2016 with 144 patients. It used to be then 118, so a survival rate of more than 10 years in 80%, and the early mortality rate was very low. So this is the final result. We see the extracardial conduit. This would be the head, and that would be the legs. And here we have the pacemaker electrodes. This is an example from my old clinic in Erlangen, a patient that used to be, that was 44, just as I am now, 10 years ago. And he was German, but of origin of Turkish origin, where he also served in the army until they found out something was wrong, and they discovered that he was a Fontan patient, left ventricular. And here you see this very large antechamber and a very good function on the right-hand side. So I always have to ask if the diastolic function is also working. So here you see the MRI. So you also see the aerodynamic. So the energy is lost and doesn't reach the lungs. So if you can't see blood, then please don't look now, because the next slides will show blood. So this is the antechamber. The atrium, so you open it, you reduce the side, you cut away part of it, then you have the channel here. This was the cortex half form, and here you have the pacemaker cables that are sewn onto it, and here you have the extracardial conduit. Then we had a follow-up MRI, and the results were very positive. This is before the operation. You see that here we had here's the pacemaker. We had the fibrillation, which was gone. Here we have the Fontan conversion in the long-term follow-up, and the exercise test. Sorry, I just want to go back. Yes. With the spiroergometry. So here we have the patients that have a high mortality rate, and the cutoff was similar to the transplant, peak out of less than 14, and that's more or less the indication for a transplant. So if the patients are not resistant, then they will not resist a Fontan conversion. The other group of patients had a much higher resistance, and they really profited from the intervention. So what we all also have to ask ourselves is, what are the right patients for this kind of surgery? We had the early conversion centers, the ones that carry out a conversion very early and don't wait until the need to do something is so urgent that it is nearly too late once you decide in favor of the conversion. So if there's a problem in the Fontan tunnel, which is not optimal, either we have stenoses, as we have seen with Dr. Illin, or we have the large tunnels, then you should actually do something and do the conversion. This is just a surgery from Aachen that I operated last year. This was similar to the other patient, a very large atrium. The right atrium is being cut off. And so you look from the inside. So this is the intracardial tunnel, which is reduced. And we enlarge the arterioseptomy. And now we have the extracardial conduit, 24 millimeters. We connected with the lower vena cava. So this is then we did the fenestration, connected it with the atrium, and the blood from the lower vena cava is led upwards. And this is the ventricular probe. The heart is beating So we set up the drainages, and the patient was very well off. He's still writing emails to me. He plays football. I thought he was the goalkeeper, but no. So the conversion rate is to be improved. I Googled this. That would be the goal. So something I learned in the European Congress is that we're expecting a new wave. So the conduits that we've implanted so far, 18 and 20 millimeters, which is the standard pretty much, are too small, unfortunately. So here's one patient which was modulated. So you have this anatomy with a larger conduit. So we look at the changed exchange of energy. So this means that we have to change towards larger conduits, 24 millimeters at least. So there's a group from Chicago that says we were wrong on the benefits of the extracardiac Fontan, and we should go back to the lateral tunnel. So the tunnel, of course, has the advantage that it is growing, that it grows with the patient. Apologies. But of course, there are different kinds of conduits. I'm not sure if the colleagues from Philadelphia have an experience with that. And we implant these conduits in the future. And I think that may be the solution for the future, that you implant something that can grow within the catheter. So we don't want the hotel on the left-hand side. We want an upgrade to the hotel on the right-hand side. Failing is not an option. This is a picture from Julia Moosmann that is taking care of her patients and doing exercises with them. Thank you very much for your attention.
Vielen herzlichen Dank. Sehr plausibel, sehr nachvollziehbar.
Yes, this was very well explained. Thank you very much. So these large lateral conduits, can you implant them early on? Or will you have to wait until the patient has at least 15 to 20 kilograms? Yes, we are discussing conduits 4 and then implant at 16, or we take the 6 grafts that grow inside of the catheter. Then with a stent, you can introduce them, and that's maybe a good compromise. Thank you. Do you have any further questions?
Thank you. Vielen, vielen herzlichen Dank.
Thank you very much.
Professor Jux.
Professor Jux is talking about the care of Fontan patient in Gießen. Wow. Here, Mrs. Enger, Mr. Gravitz, ladies and gentlemen, we've heard a lot about the long-term conditions for Fontan patients, and from a Gießen perspective, I would like to try to summarize with my own words. Perhaps I will also manage to include an aspect that hasn't been focused on. And today we learned that the Fontan's cycle is circulation results in a multi-systemic dysfunction, affecting the entire patient. The entire organism is affected, the whole person, some organs less, but in other multi-organ diseases, in measles and CS, this treatment belongs to centers, and it was put very well in my point of view. And in these centers, the post-care should be done in the follow-up care in a structured way, and there should be a scheme for that. And we in Gießen have such a scheme for children. It's different for adults, and we have 3 pediatric cardiologists, and I would like to have another point that usually comes at the end, but is also quite important. We have a psychologist, we have a psychomatic expert with us that look after the psychological treatment, and we talked about the nutrition aspects in everyday life that are important for patients. And EOL is end-of-life conversations, and this problem is important for adults, and we all have to die at some point. But did you think about the end? How do you want to be cared for? Do you want to have everything done that's technically possible? Do you want to be connected to artificial hearts? What about transplants? What about complications? How far do you want to go? And this is where the patients can think about it at an early stage. And we get to know the patients from another side. And when this situation arises, and I always talk to my young assistant, these schemes, these standards are quite important because they set the framework, and they liberate our head to look at the individual patients. And we have specialty, for example, protein loss. We talked with Mrs. Ankers from the Robert Koch Institute systematically how the vaccine state is when it comes to measles, and for example, and we see that some of the patients are immune incompetent, and we can see that the neutralization is the gold standard here. It's not just important for the patients in the current situation, but a lot of the patients are potential transplant patients, and measles is usually done after the fact. And we talked about rhythm defects. I'm not an electrophysiologist, but I'm very much in favor of an active treatment, because these people have even less capacity than people with 2 heart chambers to compensate for rhythm defects and variations. There is a group that looks after it here. We have irregular rhythms, and there is a lot of atrial functions, and these patients have to be treated at a very early stage in order to, it has to be, the Fontan tunnel has to be perforated, and then you can see here these irregular aspects, and we have to achieve a regular rhythm again. The next topic that I want to focus on is cardiac synchronization, freak therapy, CRT. It has to be done in an orderly way, and it's a topic that we know from electrophysiology with a two-chamber patients, and it's a topic that's relevant. We can see that there is a two-chamber pacemaker and a third electrode. I don't know if the heart has become smaller, but you can see the configurations that are being narrowed, and that it means that the patients can be loaded easier. And what about patient-orientated research in Fontan patients? I'm in favor of very close research that the Fontan patient can benefit from directly, and he can we look here at the relation of the atrial contraction and ventricular contractions. It's very important for the long-term Fontan patients, and we can do it in the same way that we administer medication also online, and then see what happens in terms of changes in the physiology. And we are measuring the blood pressure, we measure the oxygen level, and then we calculate the flow in the MRI. And another project that we have currently, Dr. Bakov is doing it. It's the patient-orientated research in Fontan patients, the non-invasive measurement of Fontan pressure. You can see the shoulders here. Where is the collapse point for the vena jugularis? And then we can see the Fontan cross here, and we heard that 1.3 millimeters water is equal to the same amount of mercury, and you can categorize it in the costal area. And here, two patients, one with a Fontan pressure of 14, and the collapse point at the lower neck. And this is a patient that is evaluated for transplant. And this here you can see where the lower jaw ends in the skull. And so heart transplantation is a big topic, and we are shown a lot of patients from hospitals. They have no transplant program, and here a patient, this has undergone 7 operations. 3 were done with the stents, and but there still is a gradient. And overall, as you can see, 7 operations, 7 catheters. You don't have to be a surgeon to imagine how difficult, well, it is, how much his thorax suffered, how scarred it is, and even in small interventions, you get a lot of bleeding. And so these are challenges for the surgeon. This is some pictures you can see. Here is the head with a perforation, and here around the aorta arch there is a bypass, and here the reconstructed bypass with the aorta arch. We mentioned it briefly. Single ventricle with dextrocardia, heterotaxy, and but the donor organ has the heart tip to the right, and so you had to flip it around, and again, a special challenge for the surgeon. And our results here in Giessen with the 38 patients, it's about 10% of the 300 transplantations that we had in this regard. And here you see survival rates. Especially at the beginning, we lose patients once they have managed to survive 1 year after the transplant. Then you have the same effects as people with heart muscle weakness, and due to these heavy bleeding concentrations, thinning medication has to be administered. The patients had received a lot of blood transfusions, external material, and this sensitizes the immune system, and therefore you have this acute rejection. But I would like to end my presentation with a positive example. The first transplant on a baby was done in Giessen, well, it was an infant then, but now it's a 36-year-old man. He's still living, and is enjoying his life. Thank you for your attention. Mr. Jux, many thanks for the very motivative aspects in the long term, and it's not always given. And well, you can see a very long line that will be ahead of us in the next 30 years. It's very exciting. It's very nice. Thank you.
So now I give the floor very simply
Frau Sänger
to Ms.
mit
Sänger.
dem Aspekt Forschungsförderungsprojekte von
So
Fontan.
this is about the research funding of Fontan projects. So I did change my presentation a little bit. Fontan-Herzen was very different because I traveled all across Germany to get the funding. So thanks to Julius, we started with the hope of lymph interventions for children who didn't have any chance. So the doctor said, yes, we understand you as parents, you need every single bit of hope that you can get. So we talked, we said that we needed to look at the lymphatic system, and we wanted people to look at it. So people then said, so there are so few, so you are bloating this topic, but now there are quite a lot of people, and we anticipated this. So we got the answer that if we want the answers, then we needed an award. So we had to change our structure as an association, and we started thanks to the patients, to the parents that openly discussed their children's diseases and their stories. So I would like to have the focus on the parents and on our suffering rather than having the children in the spotlight. So we want to think positively. We want to have joy for our children, but we have to struggle on so many levels that it is really very difficult. This made our project possible. So we want to promote research, our research promotion project. So we were told, we were asked that, are you researching yourself? And the important thing is to look at it and that we compare what is going well and what is not going well. So we have bad Fontan, but we don't have an idea about how they compare to the Fontan the Fontan patients that are doing very well. So we need blood tests. We need a general and unified blood test so that patients don't get a blood test anywhere, but that we have a central register for blood tests, for example, so that you can compare. So we can see what it's like with the good Fontan. So this is our questionnaire. We have 132 respondents. That's not a bad result, given that I hardly have any time to talk about this questionnaire because we have so many other things to do. So here you see more or less the questions, the diagnostics, prenatal diagnostics. 64.4% said yes, 36.6% yes, no. Our daughter is 19, so we didn't have the prenatal diagnostics. So this is an incidence that is predominant in the older cohort. Then the recommendation, 23.5 to interrupt pregnancy, termination of pregnancy. So this is my last slide to conclude. And here you see the limitations. Can you hear me still? Yes? Here you see the limitations our children have to struggle with, most of them. And I highlighted the most important ones, the physical limitations when they exert themselves physically. We heard that physical exercise is extremely important, that that we can care for a good Fontan with lots of exercise. So that will improve these data once they do more exercise. So with the help of the app, we want to motivate our children to do more sports. Then coughing up blood. I think we didn't talk about this. So many things that we didn't talk about today because everything is so complex and we cannot deal with it in one single day. Then pain in the legs, and then 15.2 are small. So we need interlocutors. So we have many people that look at our children. So problems with the blood vessels, and we don't know how many people actually get diagnosed. Then we need neurologists, maybe not in every German state. So our parents travel to the end of the world if they know that there's an expert that can help them. Then we have tics, and we have tics with 11.4%. Then we have concentration problems. There are many studies that look at the operational techniques and how to improve them. But there's a strong need for support. And there is a study that tries to gather support. So difficulty when sleeping. There are some families that are absolutely desperate because nobody can sleep through a whole night. Because the children don't sleep, they have develop eating disorders. They have to go and see a psychologist because the family have lots of limitations because of these panic attacks, and also the siblings, the healthy siblings, suffer with this, and this is something that affects people's lives every day. Then we have impaired hearing. 5.3, and we have seen that there is a connection. Then panic attacks, anxiety, it's a big problem, 31.8, and a bloated belly. We can see nearly 30%. And 29.5% has not been confirmed with PSE. So the intestines, that's when the parents ask, who can help us? Which clinic can we approach? Who's our interlocutor? Our somebody who can inform us about our options. So if I hear 30 minutes for one talk, one consultation. So we really are very lucky that our local cardiologist really dedicates a lot of time for us. But not every family is as happy as we are, because they have to deal with many different doctors. And then you have all the other problems that can arise. I think a loss of proteins, 23.5, and the diagnosis, and 74.2 do not suffer from loss of proteins. And this is about the confirmation. No. 76.7 PLE and 23.3 BP. So plastic bronchitis, there you have a possible lymphatic intervention. So the message would be to think about intervening earlier and not wait until the body is so stressed by the loss of protein. And this is a higher risk once you have an intervention. So that's a big question. So why is it going through the belly, and how to support it? So here we have 22% of protein loss. So we have many families who even fight for the diagnosis. So we exaggerate. No, people say that we exaggerate. I think Jenny is of this. Yes, she nods. So where people don't believe her and tell her that they are exaggerating. And we heard somebody here on the stage, and there was a case of the experts not believing them. So I think we have to come to a conclusion here. Ralf, Professor Grabitz, maybe you can join me on the stage so that we can have late Q&A. So thank you very much for the attention for our for my last talk about the research project, research promotion project.
Ja, na klar.
Just one more thing. An information. So it is really very expensive to set all this up and to maintain it. You've seen our team. We have a wonderful team that supports us in with the technology. So if you look at this project, please also remember that this is only possible thanks to our parents.
Ich wollte eigentlich in diese gleiche Richtung schieben.
I wanted to say
war nur
something
wieder
similar.
Schneller. Aber das passiert mir ja fast seit 20 Jahren so. Also
but
deswegen
this has happened to
ist
me
das einfach so.
for the last 20 years.
Dafür, dass,
Thank you
du
very
das,
much anyway.
Jetzt
That
das dritte
you
Mal angeschoben hast. Es ist ja
initiated
tatsächlich
this
ein
for a
absolut
third time. So
internationales
this is an
Zusammentreffen. Es ist die große
international
Chance,
conference, and
dass
this is a
ganz
big opportunity
unterschiedliche
for
Aspekte
everyone to
zusammengetragen werden
consider
kann für die
different
Besonderheiten
aspects
des
for the
Failing und des Fontans.
idiosyncrasies
Und
of
insofern
failing
merke
Fontan.
ich, dass im
So
Verlauf
I
der
can see
letzten
that
10
in the course
Jahre
of the
sich das ganz
past
doch
10 years,
wesentlich
things have
verändert
changed.
hat, wie man darüber redet,
The
wie
way
man
how we talk about it,
Informationen sammelt
the way how
und
to
wie man
collect information,
Ideen davon bekommt, wie
and
man
how we
therapeutisch
gather
auch die
ideas
Grenzen
of
weiter verschieben
how
kann. Dass
to
das
extend
Fontan nicht die
the
Heilung ist,
limits.
wissen wir.
So
Das ist, muss man
we
ganz klar
cannot
von
heal
beiden Seiten
Fontan,
eigentlich sagen.
and I
Aber
think this is clear
wir
to
haben alle
everyone.
die Chance,
But
die
we do
Kon-
have
die
the
Verhältnisse
opportunity
in den
to
nächsten Jahren,
change
Jahrzehnten weiter zu
things
verbessern.
as they
Also
are now
ich bin
in
sehr froh, dass
coming
ich
years.
eingeladen
Or,
worden bin,
so
hier
I'm very
vorne
happy
zu
to have
stehen
been
und
invited
immer
to
mal kleine
host this
Sätze zu
event
sagen.
and
Und,
to
gebe
contribute
deswegen
with
das Mikrofon erstmal
one
weiter.
or two little sentences.
Also,
And I give the floor back to you. No, it's not necessary. Thank you. A big show of hands, please, for Professor Grabitz for doing a wonderful job here on stage as our host. Because this day means a lot of work for all of us, the preparation to travel here. I hope that our team, our children, and everyone being happy about this event and everybody preparing for this event has shown you how much, how grateful we are that you are with us. I wish you a wonderful trip home, especially to the US. So it really means the world to us that you have actually come here from so far away. And the international character of this event for our German children and also for everybody else, for all the other children. So maybe with the app, we will have an opportunity to reach the US. Who knows? And Stefan Raab, our Stefan Raab, he knows that this is our wish, and that maybe we have this registry that was presented earlier on, and to establish a contact, and our families get the information. I will just get something, because we have this wonderful lion. You can always, you can also stick it on your car. Everyone who is involved in the first phase of introducing the app will receive a lion sticker, and everybody else who wants one can ask us. We also have T-shirts. So now that's it. Thank you.
Vielen Dank und
Thank you
gute
very much,
Heimreise.
and have a safe trip home. Thank you.